A very good evening to all present. I am Dr. Uttara Mohan from the IIP Digital Media team. The webinar for today is how to recognize red and yellow flags in outpatient physical therapy. The resource person for today is Dr. Raghu Chovvath. This is being organized by Kerala Prathanam Titha branch. We are streaming live on IIP India YouTube channel. So I request all to subscribe to this channel to get regular notification for our live webinars. Now I request the Kerala team to please take over.
Thank you, ma'am.
Thank you, ma'am. Good evening, dear doctors. I would like to extend a warm welcome to all to this continuing physiotherapy education. I'm Dr. Vinci on behalf of IAP Pathanamthitta chapter to lead you all through this today's session. I request Dr. Convener to call the meeting to order.
Dr. Nisha, please unmute yourself.
Madam, go ahead.
I, Dr. Nisha, in the capacity of convener, IAP Pathanamthitta branch, I here call the webinar session to the order.
Thank you, sir. By the day, the Lord directs his love. At night, his song is with me. Prayer to the God of my life. So let us begin this meeting by seeking the blessings of Lord Almighty with a silent prayer. Thank you. Welcoming is the noblest act of any function. Moving on now, I request the Secretary of IAP Pathanamthitta chapter, Dr. Vishal Johnson, to deliver the welcome speech.
Respected Chair, the Convener, Dr. Nishadas, Honorable Chief Guest, Dr. Raghu Chovvath, Madam, most respected and enthusiastic State President, Dr. Srijit M. Nambudiri, Sir, eminent and most respected resource person of the day, Dr. Raghu Chovvath, Sir, our backbone and State Chapter Vice President, Dr. Vinod Raj, Sir, most respected State Secretary, Dr. Jim Gopalakrishnan, Sir, IAP Women's Cell National, State and District Representatives, our branch Women's Cell Coordinator, Dr. Savita Madam, dignitaries, National Technical Team members, and fellow physio doctors. It is indeed a great day in the history of IAP Pathanamthitta chapter to be a host for a national program like this. In this pandemic period of our branch, in this pandemic period, our branch executive members find time in making at least one program a month. It is a real blessing that our executive members are so active and enthusiastic and work with great unity for the upliftment of our profession. For the past 2 years, we are conducting various programs like continuing physical therapy education, training sessions for physiotherapists, public awareness programs, newspaper supplements, and various other programs, including charity works. Without taking much time, let me move on to my duty in welcoming all. I would like to welcome our branch convener, very active physiotherapist and a true leader who leads from front, Dr. Nishadas, who presides today's academic session. Dr. Nishad, on behalf of IAP Pathanamthitta and the whole entire team, I welcome you. It is a great privilege to have our one and only legend, Dr. Raghu Chovvath Madam, who is our chief guest. As we all know, she is the national treasurer, where she is successful in making an excellent system where our membership procedures are really fast. Last month, one of my budding physio membership requests was completed within 8 hours, and he got his professional membership certificate within 8 hours. So really, it's so fast. Respected madam, we are glad that you are in our midst. On behalf of our IAP Pathanamthitta Kerala chapter and all doctors joined in this webinar, I wholeheartedly welcome you, ma'am, to this academic session. The Iron Man behind the Kerala chapter formation, enthusiastic physical therapist, great leader, and a man with great vision. It is none other than our Sri sir. It is a great pleasure for us to have you in our midst, dear sir. On behalf of the entire team, I would like to welcome you, dear sir, dear Sri sir, to this academic session. The man of today, great scholar, good clinician, wonderful teacher, and above all, a good human being. I would like to welcome our resource person, Dr. Raghu Chovvath sir, in our midst, in the midst of his busy schedule. He promised us to conduct an academic session on the topic how to recognize red and yellow flags in the outpatient physical therapy. On behalf of National IAP Technical Team, State Chapter, and Patnata Branch, I wholeheartedly welcome you, sir. I would like to welcome our State Secretary, Dr. Jim Gopalakrishnan, sir, who leads us in front. And also, I would like to welcome Dr. Vinci Daniel, and all other technical team staffs and all the dignitaries on and off the dais, and also all the fellow doctors who have joined in this webinar. I wholeheartedly welcome everyone to this wonderful session. Thank you so much.
Thank you, sir. Request the convener of IAP Pathanamthitta chapter, Dr. Nishades, to deliver the presidential address.
Hello, good evening, everyone. IAP Pathanamthitta greetings to all the peoples, those who had participated here. Our webinar section topic is very important in our profession. Dr. Raghu Chovvath, he is taking the webinar section. We know he is a very famous and intelligent resource person, and he is very famous in international level also, with a lot of experience. Today's honorable chief guest, Dr. Raghu Chovvath madam, he is a very powerful leader of IAP, and guest Dr. Sri Namburi sir, the state president of IAP Kerala. We know he intervenes all the affairs of physiotherapy profession, and he gives all kinds of supports with his leadership. And Dr. Jim Gopalakrishnan, the secretary of IAP, and Dr. Vinod sir, all leaders are here because of all national leaders and state leaders with their presence. This meeting is very great event. I thanks to all for the valuable times here. Last 2 years, IAP Pathanamthitta is working very actively with 14 members of executive members, including office bears, women's cell members, for the development of fellow physiotherapy profession and the community-based programs. The programs like webinars, posterlies, medical for physiotherapy camps, and other so many programs we are organized. We personally organized the program of Punarjani 2021. Kerala Honorable Health Minister inaugurated this program. In Punarjani 21, we aims to the people for the community educating program and the rehabilitation of COVID and post-COVID patients. I appreciate all the team members and all the members participated here. I wishing all the best to everyone participated here. Thank you.
Thank you, sir. Our chief guest is a native of Delhi, completed her master's in orthopedics, having an experience of more than 2 decades. She is none other than Dr. Raghu Chovvath, the National Treasurer of IAP India. Now I request our honorable guest to inaugurate today's session and to deliver this speech. I am profusely overjoyed to take the opportunity to introduce our guest of honor, He is the legend of IAP Kerala chapter. He has motivated us all by being a living example of kindness and self-service to IAP. Now I request Dr. Srijit Nambudri sir, the Kerala State President of IAP, to deliver his speech.
Good evening, all. Respected National Treasurer Raghu Chovvath ma'am, the great resource person Dr. Raghu Chovvath, and other national leaders and the IAP Technical Committee and district leaders, IAP members, physiotherapy students. Good evening, all. I'm happy to be a part of this national-wide webinar, which is going live as well as in YouTube channel. Our Chief Guest Ruchi Varshini ma'am is traveling from Punjab to Delhi. She's on the way. She will join us when the connectivity is okay. And today we'll be sharing our time with the great personality, Dr. Raghu Chovvath, who is known to many of the physiotherapists in India. Last year, he was with us in IAP conference, Chennai, and he's a great teacher as well as a great scholar who always happy to share his knowledge with the budding physiotherapists as well as his colleagues. Hope he will be having a great time with us. All of us will be mastered many techniques, but many of us won't be caring about the red flags and the yellow flags, which may endanger us as well as our patients. So it is better to have it with a great person who is always keen in not making any harm to the patient. So I think we'll be having a great session ahead. And one more thing, we are having our 59th National Conference on January 29th and 30th at Kolkata. Now registration process is going on. Hope we all will be able to meet in Kolkata. IAP is trying to unite all physiotherapists and trying to bring all physiotherapists in one platform. So we will have great association, and we will fight for our existence as well as our rights. And I wish Dr. Raghu Chovvath all the best, and all the participants have a great evening with him. Thank you.
Thank you, sir. Now I request our IAP Kerala State Secretary, Dr. Jim Gopalakrishnan, to felicitate.
Hello. Good evening, all. Am I audible?
Yes, sir.
Thank you. Respected National Treasurer Dr. Raghu Chovvath, respected State President Dr. Srijit Nambudri, resource person Dr. Raghu Chovvath, Dr. Nishad, convener IAP Pathanamthitta, State Treasurer Dr. Baiju, State Vice President Dr. Vinod Raj, Dr. Vinci, Women's State Coordinators, all state office bearers, as well as all IAP district office bearers. A very good evening to you all. So again, after a couple of weeks, we are again with a strong webinar, and such a wonderful topic has been chosen, and such a wonderful resource person we have. As rightly said by our state president, see, we all mastered so many techniques, and we found it very much helpful in our clinical practice. But you know, the red flags and yellow flags, every time you should be very much aware about. If you are not giving any improvement, that's it, that's okay, fine. But you are damaging or creating more trouble, creating more trauma. It's a very big issue. So in the clinical practice, like in abroad, you'll be sued by the patients and by bystanders. But here, the laws are coming up, and the people are getting aware about the laws. So you must be very careful while treating in an OPD or an IP basis. When you touch a patient and you treat a patient, you must be very confident, and you must know the indications and contraindications. and check out the red and yellow flag. And that's such a wonderful topic and such a great experience. Like, all must be aware about what you're going to perform with the patients. And sir is very, very experienced and highly talented. We are very gifted to have him here today for this webinar. So without taking so much of your time, and I wish you good luck for this webinar. And thank you, Dr. Raghu Chovvath, for spending this evening with us, and congratulating IIP Pathanamthitta branch and the whole IIP Kerala team to hosting this webinar. And technical team of IIP National, I'm thanking you again for this wonderful support. Thank you, Ananta.
Thank you, sir. We are delighted to have an eminent and intellectual personality, having graduated physiotherapy in January 1988. He is basically from Palakkad, but brought up in Chennai. He migrated to USA in 1995 to improve his professional skills. He completed his DPT program from A.T. Steele Institute of Health Science in Arizona, and a fellowship in orthopedics manual physical therapy from Regis University in Colorado, and is a fellow of American Academy of Orthopedic Manual Physical Therapy. He is a clinical instructor for DPT students from Wayne State, Michigan. He is now certified in dry needling and has further strengthened it with self-erring safety study on an embalmed cadaver for the upper quarter. I hereby welcome Dr. Raghu Chovvath for the wonderful session to enlighten us with his resource on how to recognize red and yellow flag on outpatient physical therapy. Welcome you, sir.
Okay, good morning, everybody, because it's morning for me. You guys all woke me up. So if I'm going to sleep halfway, wake me up, I think. But what an energetic crowd, and I'm very excited to be here. Thank you all for the kind words. And you just suddenly put me in spot. Vishal in the morning put me in the spot by saying, "Sir, there will be more than 400 people here." I said, "Oh my God, now I have to be better." So I hope all my shirt is buttoned and I'm looking okay. All right. So good morning, anybody. And I have to really say your president nailed it to the point when he said in his speech that we are becoming masters of our technique. Also, Gopalakrishnan was saying that we are becoming master of techniques. Okay. What does that make us? That makes us good technicians. Is that what you want to be? You want to be a good person who can take a good X-ray, not belittling that profession. But what I'm saying is we are not trying to be that. We are trying to be the primary care providers of musculoskeletal practice or any musculoskeletal event. In fact, we are already in that phase in most developed countries, especially like UK and Netherlands and other places. The primary triage for musculoskeletal, even in the United States Army, is done by physical therapists. You know, if physical therapists are getting to, and in the United States here also, we have been, they are already researching on that. In fact, one of my colleagues here in Michigan, graduate from Chennai, he's in fact a PT in the emergency room. So you might ask, what is a physical therapist doing in an emergency room? Pretty much all musculoskeletal, the referral doesn't go to an orthopedician or a neurologist. The physical therapist checks out and decides whether to discharge the patient or to refer further out, or just give some advice or do some treatment. So what is that? That makes us much more responsible to have to know when not to treat the patient, isn't it? See, somebody said very wisely that a specialist is a person who knows his limitation. First of all, we know so many techniques and everything. Does it mean you can use it on everything? A simple example is, if I say this to everybody, all my students, remember, if the only tool you have is a hammer, everything looks like a nail. So you should collect as many tools as possible. And one of the important tools you are going to collect is to make sure how to know when to refer somebody out, or when the person is not a candidate for your care. And you know what? We do not have to have. A lot of us might be confused. I was too when I was young. Is that, oh, does that, if I send that patient out and say that it is not possible for me to treat, will I lose the patient? Will I be thought as somebody that is not capable? No, trust me, most patients love you. I'm going to give you an example. Most patients love you when you tell them, sorry, I cannot do anything more. You have to see so-and-so. They call me, they come back and tell me, oh, thank you so much for doing that. I'm so much better. You understand? So the whole goal of this class today is we do not have a whole day to do this or anything. We have an hour, hour and a half at the most. What are we going to do here? My expertise is an orthopedic physical therapist, and my specialty more or less is in outpatient physical therapy, dealing with pain. And now, in fact, the way our practice has progressed, our 90% referral source are primary doctors. We get like maybe 5 to 10% from specialists like orthopedic surgeons and spinal surgeons, but the rest all we are having from primary care. So the primary care may do just basic assessments on your patients, and they are trusting that you will do the rest and call them back. So our responsibility has increased much more. So I'm coming here and teaching you guys from a standpoint of being a physical therapist who will be able to assess our patients, make a decision if they can be further treated with physical therapy or not. I don't come here from a standpoint of a researcher trying to teach you how to do research in this subject. I am just a plain old clinician. That is my specialty. Then does that mean we are going to neglect those guys who do the research? No, we are going to take the information from them, and we are the people who apply it in the clinic. Okay, so that is how you should look at this webinar. And also, please look at this webinar as an eye-opener. It is not, don't think that you are going to go at everything, because remember of the old saying, I don't know how they say, but they say here is that don't give somebody a fish, but teach them how to fish. You understand the concept? So today I come and give you a fish, your hunger might go away. But if I teach you how to fish, then you will be able to eat all the time. So the whole concept is to introduce how to recognize red flags. And you will see that even the world does not have set standards for that. So none of us are in bad shape. Okay, nobody has. So even the research I'm going to present and show you are going to be so new that even the end of that, those tools that I'm going to show you are not finalized yet. In the plan, they are just getting, to be more evaluated, and then it is going to show more and more results in the coming years. But they are good tools, and we have used certain tools which are really good. Okay, so that's where we are coming from. So you can use all the principles that we do here and apply it in your practice and be careful. But the good news is, the very good news is, what is the very good news? That the red flags are not that very common. Okay, but that again makes it important to be able to identify it, because you are not going to see it so often. Always be ready to find that one. We are going to see the percentiles, and you'll see how small the percentiles of red flags are, and you're going to find out how small that is. Okay, so if you guys all understand where I'm coming from, we'll go to the next slide. What is this? I put up a slide here with so much, it's all crowded. I can't read anything. There are so many dots, but right in the middle, it looks like there is pain. Hey, that looks like what happens to somebody when they get married. No, I'm kidding. No, I'm really, this is from this article that came out recently, a clinical commentary, which says, can biomechanics research lead to more effective low back pain? So they're looking at seeing that if biomechanics change, can change your low back pain. But what is the first thing they put up in that article? They said, look at how many factors are involved in a simple low back pain, of which, if you guys look at, we are very well versed with tissue damage, mechanical factors, and some biomechanical factors. But are we taking into consideration this sensory and emotional experiences, central sensitization, low physical activity, timely treatments, beliefs and cultures? See, so many of these other factors also form, all these important issues also form the crux of the problem. So if you want to deal with a lot of your patients, you need to be addressing all this. Okay. Now, if you say tissue damage, then you can say, okay, I know so many tests. There are orthopedic tests that I can do to understand where this is coming from and where I can treat. But you also need tools to find out if the other problems are there. And in today's webinar, we are going to deal with two things. I'm not going into your biomechanical or other things, but we are going to see in the biomechanical first, what are the ways to rule out that dangerous situation? and the other situation that involves these things, unpleasant, and all these psychosocial issues. So before we go into that, we need to understand, knowing this, it's too crowded. Let me make it more simple to understand. All problems we are seeing have three main components to it. Unless you do not address effectively the three of them, you might get partial improvements, or you might not do a full job, or I'll put it a different way, you will get a great result if you address all three of them. So what are the three of them? The three pillars of any problem that in musculoskeletal that they come to see you, they have biological issues causing the problem, and there is psychological issues that complicate it or make the problem itself, and last but not the least, social problems. What do we make a social problem? Somebody might have a serious problem at home. They are alone and they have to cook for 10 people, clean and do everything, and they have a back pain and there is no way to give them a break. That is a social problem. You could do the best techniques in the world. You could do the best treatments in the world. You can teach them all posture, but how can you stop that excessive amount of activity that is being done, especially at early phase of treatment? You need, so understanding not only biological, psychological, and sociological issues will and is necessary for effective management of a problem, okay? Of which we are not dealing too much with bio. In the bio, we are going to deal only with the red flags today, because an important part of biological reason for the pain can be a serious issue that needs to be referred out. And the second important issue that we are going to check and be able to recognize are psychological issues or yellow flags. So without much issues, let me go to the other slides that we are going to see. Now, at this point, I'm going to ask you, please, one of you can tell me, am I going too fast? If I tend to speak too fast, please let me know. Please don't hesitate. And please let me know if I am going too fast. Okay. So as of now, you understand that we are going to look at in the biological part, we're going to look at how to recognize the red flags. And in the sociological or the psychological part, we are going to look how to recognize the psychological issues. That doesn't mean it is the end of it, but that is the topic of the webinar today. So there is a big concept of social. After this webinar, I hope you guys will all try and access it, because social attitudes, beliefs, economic situation, everything differs from where I practice. And I might not be an expert on that because I have not been in India for the last 25 years. So I'm not be an expert in those ideas, because attitudes and beliefs change constantly based on the present day events. So you guys will be a master of that. You should find resources to be able to get to that issue. So we are not touching the social, but I think psychological are pretty much worldwide. Human beings all have the same amount of problems with that, and biological also, with some differences, which we will touch upon. Okay. So like I told you before, there is not much consistency in the world on how to access or how to assess red flags. So in the recent past, this is the very first document that was published in JSPT. It is an international framework of red flags for potential serious spinal pathologies. And while I'm doing this, I will be prominently putting up all the sources from where I got this. And if anybody, please look through, you guys are everybody, every institution, most of my referral sources are from JSPT or physical therapy journals, which are accessible online, and please get them. And if you don't have, I can either get one of you a personal copy so that you can look at it. I think this might be free access, I don't know, but please check online. It's available in JSPT.org or JSPT. If you just do JSPT, you will be able to search for it. It's a journal. Okay. In this journal, in this article is the first framework that came out for thinking about red flags for potential serious spinal pathology. So what is a definition for red flags they gave? They said that red flags are signs and symptoms that raise suspicion of serious spinal pathology. Now, why did I put this statement? I've been telling the same thing over and over. Why did I put this statement on there? Read it carefully. It says red flags are signs and symptoms that raise the suspicion of serious clinical pathology. Doesn't mean they have anything serious. That means it's just raising a suspicion of spinal pathology. Okay. And in the literature, they said there has been 163 signs and symptoms that were reported as red flags, of which 119 were from history and 44 from physical exam. Now think about it. How is it practically possible to remember all of them and check it on every single person? It is not practically possible. I don't know how you guys do. For me, I have a patient every half an hour and an evaluation 1 hour. In this time, I have to take all their paperwork done, sit, have an interview with them, and they expect a treatment. And in the middle of it, I will have somebody come and disturb me for something else. So within the short period of time, how do we do it? So we need some amount of structure, and every physical therapist need it. So that is why if you look at the authorship of this article, the authors are from everywhere around the world. They are from Australia, England, USA, Canada. So they have been internationally across the board, and they have tried and attempted to create a framework which we as physical therapists can follow. And thankfully, this framework is not for any other profession. It is specific for us. But hopefully we will have guidelines like this for all other areas also. For right now, we have for spine. But as we all know, most serious problems are found in the spine, because I think extremities, we might all, as we discuss that, we will see that we might be able to recognize them much easier than the spinal ones. Okay, so what does this say in this framework? In this framework, they said we should approach, or they did approach making this framework based on these three factors, or using these three factors. What are they? They looked at the epidemiology, or the prevalence of red flags, and then the risk factors associated with each red flag, and a clinical picture associated with it. So they just did not say, okay, the epidemiology says so much, so I will do automatically on everybody this test. No. And the same way, oh, this person has a risk factor, so does he have it automatically? No. So they did the epidemiology. They said there is a pretty much probability of this happening this much. And does this person have certain risk factors? Yes. And then does it correlate with the clinical picture? When all these three fell, they thought, oh, this person might have serious red flag. But even that, they mentioned very clearly that not all red flags need to be immediately, the suspicion of red flag need not be immediately acted upon. Based on the seriousness of the condition, you should be able to make a justifiable decision whether I have to send it out immediately or can I wait and watch for a day or two. I'll tell you why that is important. Okay. Now, if you guys understand that the red flag is not an instant thing. So the problem with youngsters is when they come out of school, college kids, they come out, they come, and when they are in my clinic, they're like, oh, we should send this out immediately. No, we don't send anything out, but we will be cognizant of the fact that this is raising some flags. Let's wait. Let's not do anything aggressive. Let us see how this is proceeding. If it's proceeding well and good, good. And I'm going to give you examples of that as we go with each of these things. Then we can always decide whether or not to keep them or send them out immediately. But there, some of them are absolutely essential. I see them, we call the doctor right away. You understand? So that's where we are going to. So for this first, let us look at the first factor, then the risk factor. First, let's do the epidemiology, risk factor, and clinical picture. Most of this research has the data. I could get data only for the spine. So use this as an example and start looking for yourself for more data on extremities. But good news is extremities are low, and the most important ones I have put in as much as I can. Okay. So going into the next slide, this is what they found. This is epidemiology. This is the prevalence. Prevalence means of how many patients that comes into a primary care physician's office versus a spinal surgeon's office, which is at the way at the end. See, this is a spinal surgeon's office, and this is a primary care. And the primary care, when they say primary care, can be your primary care doctor or you, because a lot of patients, like I bet most of you primary care physical therapists who have their practice, you have so many patients who trust you more than going anywhere, and they're going to come and see you. So they're saying, what is the probability of this person having that red flag? So let's look at that. So first is cauda-equina syndrome. Why is that in the first? Because literature is telling me that the high amount of medico-legal cases in the United Kingdom is associated with missing cauda-equina lesions. Okay, so we will see what are the signs and symptoms, how to recognize it. Okay, so the quad-eye equinnulation. So the quad-eye equinnulation, what is the probability that you have quad-eye equinnulation? What is the prevalence? The prevalence is only 0.002 to 0.04 when the person has low back pain. So do you see how low it is? It is only 0.04, not even 1%. It's less than half of a 1%. So 0.002% is the most of it. But sometimes some people have reported 0.4%. And the funny thing is, this thing is even in the spine surgeon's office, is 0.04 with low back pain. The second one is compression fracture. But remember, guys, this in developing world is going to be one of the important things you guys have to remember. And we will talk about it in detail, because look at the prevalence of all of this we see here. The highest prevalence is that of compression fractures. It is 4.5% in primary care. 4.5% in primary care to 5.6% in spine surgeon, because a spine surgeon is going to get a lot of people, plus in the ER, in the emergency room or casualty, however you call it, they have a higher percentile, because post-op, that is automatic, because post-accidents people show up in casualty rather than come to use. And so that's why the percentile is high. But the important thing to know is there is 4.5% prevalence of compression fractures noted with primary care. So you have to be very careful. We're going to look at where it is common and who is more vulnerable to get it. Okay. Then regular fractures is less than 1%, because if there is a regular fracture, they're going to end up in the ER. That's why they didn't even put numbers for that. The last, or not but the least, the biggest fear most of us have are malignancy, or are we doing some harm because this person has cancer. Think about it. They say the prevalence of cancer is only 0.7% with non-mechanical back pain. That means when you test the person, you don't see a mechanical issue. What does that mean? When do you have a mechanical issue? Think about it. A person either is unable to bend. If a person can't bend with the spine, maybe they become comfortable in extension. So a person who's uncomfortable sitting down likes to stand. He feels better, or lying flat feels better. So that is mechanical, clearly, isn't it? Or right rotation is better than left rotation. Right side bending is better than flexion. Right rotation is better than flexion, left rotation, or extension, left rotation. These are clearly mechanical signs. But if you don't find any of the mechanical signs, sometimes you have people who have pain, but their range of motion is absolutely free and good. How can that be possible? You understand? Those are suspicious signs. That's what they're calling that. If you get back pain or other pains with with non-mechanical signs, there's a probability of, even that is really slow, 0.7%. But look at it, it increases to 6.0% in a spine surgeon. Why? Because all the malignancies treated by every other, every other physician is referred to the spine surgeon. So the prevalence rate is pretty high there. Okay. So then comes infection, which in the developed world like us is very, very low. That means they do surgeries like 7-hour surgeries with fusions from T7 to S1 in one session on an 80-year-old with no issues of infection. So that they are so confident. So that is why they are saying they're non-mechanical and the probability is 0.01% in primary care. But it increases to 1.2%. Even that 1.2%, 30% of them are all post-op discitis. So remember, the probability of infection is low in the developed world and can be a little bit higher in the developing world. So you got to be careful about those issues and be able to assess for infections. Okay. But again, the one thing that stands out is these people show up with the pain with non-mechanical patterns noted in their spine. Sounds good? So this is for the epidemiology. Now, but take this with a pinch of salt again, because this is an old study from 2009 done in Australia, where they did a and 1,172 consecutive patients receiving primary care for acute low back pain, of which they found 11 cases of severe pathology, including 8 cases of fracture. The clinician identified 5 of the 11 cases of serious pathology as initial consultation, and the rest 6 were false positive diagnoses. But the most important thing I want you guys to look at this here is that despite the low prevalence of serious pathology, most patients of this 1,172 consecutive patients, 80.4 had at least one red flag. You see that even the patients who had nothing, these are all, they were confirmed later with other diagnoses. They still had 80.41% of people at least had one red flag. That means just having a red flag is not a contraindication to treatment. Is your ability to analyze whether it is serious is an important aspect. Okay. And sometimes you have to do it like this. You will treat under caution. You will watch constantly. So where does this become important? This becomes important when, as a single provider, if you are in a single practice, you see all the patients, you can keep it in your mind. But if you are in a multiple practice, you have other PTs, and in our country here, we have PTAs, of physical therapy assistants. So if you're handing over a patient to them, you better explain clearly and tell them, I am suspecting something. So report back to me. We might have to reassess it in a constant fashion so that we don't miss the red flag. Because we are not throwing every patient out just because there is one red flag triggering. Okay. Now, thinking all this, after having said all this, it makes it confusing. So how do I do it? How do I go about? You said epidemiology. Okay, the epidemiology tells me it is very low, but I still want to make sure that I want to rule it out. So what we do, and I don't know, you guys might be doing for ages in the United States, everybody gets forms to fill out when they come in, and there is a general health form. Patients will tick yes or no, and every place has its own form. They all created a review of systems form. So there was no kind of equal thing going around. So the good thing happened was Stephen George is a very big name. If you look at this article, he's a very big name in psychosocial issues, and he's been doing papers for a long time. He came along and he created this big consortium that had clinics across the country, across the United States, in 5 different states, 5 different regions of, if you can split up America into 8 different regions, he was able to collect people in 5 different regions, different clinics, and created this and tried to find the correct questions to ask so that an initial, a screening can be done on people to see whether they have red flags. And that is what he calls it, an optimal screening for prediction of referral and outcome. Trust me, the outcome part, what does this mean? This means this is a tool with which you can predict whether I have to refer the patient out or check whether how the outcome is. Trust me, they have not come to the part of outcome yet because they have not made enough data. So this will be a good tool for referral. And there are 2 kinds of OSPRO here. We are going to talk about it. One is OSPRO ROS. ROS means review of systems. And the second one is OSPRO YF, that is yellow flags. We will discuss the yellow flags later, but we are going to discuss about OSPRO. Why did I put it in there? Oh, you can say, I'm not research. I'm not going to research. No, but remember, like I'm sorry, one of your president or one of the speakers said, Gopalakrishnan said, I remember, that we are also getting to become a litigious society where people are going to sue, and I need to have tools. So if it comes up to a point, we are all human. At any point of time, things will come out, we will miss out something. How are you going to justify that you did everything best possible? At that time, you can say, look, I use this validated tool called OSPRO, review of systems, which they have found that most triggering of a red flag happened with these questions, which have been studied extensively in research. And it's a very simple thing. So just make sure in the next slide, I'll show you. So first, in this research, they all came up with 93 questions that they can ask, including all the systems of the body, to be able to flag a red flag. Okay, to be able to say, okay, there is a probability of a red flag. But think about it. Is it practical to have 93? So then they talked about it, and eventually they have come with an understanding that 23 of them are essential. And further, even 23 people complained, oh, 23 too much, my patients won't my patients won't answer them. So they came up and said, you can at least use 10 of them. You know what? You can use the first 10. And they said, even with the first 10, I'll show you. See, these are the 23 questions. Pretty simple, isn't it? And a lot of you already are saying, oh, I asked this question, I asked this question, I asked this question. But did we ask all of them? And did we know that it is validated? And again, remember, going back, just because somebody said one of this is ticked off doesn't mean they have red flags. But on the same count, remember, if I'm going to give them a 23 of them and they tick 5 of them, then yeah, yes, there is something going on. Let me do more clinical assessment. Remember, it is epidemiology, and you get the risk factors and then clinical picture. So let's see if the risk factor shows up in the screening. Okay, this person looks like they have this clinical thing, and then do that. And also, please read through. They have really used their heads and put the questions significantly. Look at one of the questions I like. You know, how many of your patients say, I have morning stiffness? The worst is when I get up in the morning. Okay, immediately does it say a red flag? Absolutely not, because trust me, 90% of all my patients say they have morning stiffness. But look how they have put the question. They said, have you recently experienced sustained morning stiffness? That means that the morning stiffness went on for a long time. Most of your patients say, you know what, when I first get up, it's stiff, but I walk up to the bathroom and come back, I'm fine. Then I can move on. So that is normal. But when it is sustained, like it goes on and through the day it lingers on, then something else. Then you start assessing and looking for other signs, which we will show the other one. So this is this 23. You guys can create this and put it as an initial questionnaire to your patients. They can check off. You can keep, and you can, when if something comes up later, you can say, look, the patient did not say anything. Okay, so I did not find it important, but this could be the single tool where you find 3 of them correlate. Like you saying, yeah, I'm experiencing some chest pain with rest, and I'm getting shortness of breath, and I feel like I can't walk long. I'm sweating excessively. So a picture starts emerging. Okay, back pain, I have abdominal pain also along with it. Because why is this important? How many times a patient, I don't know if how many of you have experienced this. They will think, I'm just seeing a physio. I don't need to tell them about, I'm not able to pee for the last 3 days, or I'm having burning when I go to the bathroom, or I'm having problem with sexual activities causing me pain, or I can barely. I'll give you examples of that. See, I had a patient the other day. She came in and she has all the risk factors, but she has been treated. She's got malignancy. She was worried about it, but she had gone through her chemo. Right now she's in remission and she's already very anxious. On top of it, she tells me, I have this back pain and they've treated me and they said nothing, go to physio. And she's got this back pain is bugging her. But I kept on asking her. Then she said, can you close the door? I want to tell you something. I said, yeah. And guess she said, oh, you know what? When I have sexual activity, I have really strong pain. Then I said, where? Then she starts pointing out to mid-thoracic. And then when we checked, all she had was a really strained oblique muscles of her abdomen. And she was contracting the abdominal musculature, causing the pain. So when we taught her, we taped it a little bit, did some manual techniques for it. And she's much, much, much better, even though she's still anxious about whether her cancer is coming back. But other than that, her lifestyle has improved. She's moving freely. She's going to work. She's able to exercise. And we are gradually increasing her ability to tolerate contracting her. Then after that, when we start doing assessments on her, she can't barely sit up straight. And especially if I put that oblique in fashion with a little leg bent and turn to the side and try to get up, her pain exacerbates. It shoots like crazy. So clearly, a deep questioning that is out of their comfort zone, and that what doesn't feel like that needs to be communicated with us could give us the thing. So this tool could point you to the direction to ask questions. Okay, so that's exactly what they created this for. So you can use this. You can use this sheet in when they come in. Look, it's not too much. It's small. I put it in one slide just to show how it is not too bad. Okay, and it will be preferable. Please do this. See if you guys can translate this in the local language and give it to your people also, and it will really help out for them to make answers to this. All right. And in giving them in a piece of paper, sometimes they are much more confident to say yes or no regarding, they are very much more confident to mark it because they might be not that comfortable telling out these things. So this is one thing that is called the ROS, or the review of systems, and it is validated. And how is it validated? They found that the 10-item version identified 95.4% of time at least one item for red flag. When you do the 23-item version, they said it could catch up to 100% accuracy of some red flag going on. That's that. See, it is just identifying. Remember, it is a screen. It is a screen. You don't have to make the full decision based on that. That is why I didn't show you this one first. I showed you the other article first to tell you how that you do not have to immediately respond and jump and send somebody out to the doctor. You have to make the decision. But this thing will give you to keep in back of your mind. And where does it help me? I wouldn't take this person and immediately try and do aggressive things with this person. I would watch, wait, and when I'm confident there is nothing there, then I'll start doing more aggressive manual techniques or exercise prescription or other modalities or anything you want to do. You understand? So that is important. And this is a very validated tool, and it's a good tool. You can either preferably get the 23 item done by everybody. And if they do not do the 23, at least have them check off the first 10 of them. Okay. So that's important. So now you know that you have a tool to rule out the review of systems, right? And what does it say from here? From all this explanation I've given you, what is the most important thing with your patient? Before you put your hands, and when they walk in, don't decide. You say, oh, I see them walking this way and they're leaning, I'm going to do this technique. Do not do that. Do not judge them with anything unless and until you sat them down. So anybody comes to my office first for evaluation, you know what I do? I make them, we have a chair in the room. They sit in the chair. If they are comfortable sitting down, sit in the chair. And I'm on the other side of my couch. I'm sitting on a chair with my laptop and I'm saying, okay, let's talk. So tell me from the start. Oh, some of them get upset. They say, oh, didn't the doctor send me off information? I said, yeah, he did. But he didn't ask all the questions, what I need to know. So come on, you tell me first. I let them, I don't ask them questions. And again, please, when you ask questions, do not ask leading questions. That means I won't ask, is your pain sharp? I'd say, can you describe your symptom? They say, what do you mean? I say, what do you feel? Tell me. And then I also tell them, look, I'm not putting you in the spot. There is no correct answer. You can tell me anything. So when you give them open-ended and they can say anything they want, you start getting information. And this is how you collect. And this collection of information with your knowledge base is going to make you decide whether I need to send this person out or not. So the sitting down and doing after this, then I do a basic walking. Everybody, even it's a neck, shoulder, you walk for me. I want to see you walking. Why? Because you know how many times we caught cervical myelopathies, the doctor didn't catch. You know why he did not catch? Because he didn't see the patient coming into the room. Somebody brought the patient into the room and the patient was sitting down. He walked in, talked to them, and she said, you know what? I have a back pain. I'm telling you, this happened to me. The patient, she was suffered to me for back pain. On day one, when we did a thorough evaluation and we tested, we found that she had upper motor neuron signs and she's got cervical myelopathy. How did the doctor miss? I know the doctor. She's a phenomenal doctor. She is very knowledgeable because she went into the room. I asked the patient, oh, she never saw me go into the room or come out of the room because she would have seen the gait disturbance the minute you see somebody. And then I called the doctor and said, doc, it looks like there's upper motor signs. Can you take a look? She says, okay, send her Raghu. They send her right away and put her to MRI. You guess what? Within 1 week, she had cervical decompression because there was significant stenosis with, again, I'm going to tell you, I treat cervical stenosis all the time. Not all of them go to surgery. They don't need to. But when you have progressive upper motor neuron lesions, like the patient telling me that she's been progressively having to use a walker and her handwriting was going bad, she was dropping things, and also she was getting some swallowing problems. I know there is a progressive neurological deficit, and I made a decision. That is a red flag that needs to be sent out. Does that make sense? So you guys have to have a thorough knowledge and a lot of discussion. Remember, sit and talk. It's your patient. You're going to make lifelong decisions. I'll show you how I'm somebody I totally didn't do anything, came back and thanked me profusely 10 times. I'll show you that one while we go through some of the things. Because why? Because we made a decision to send them out. So make sure, do that. You will get more clientele that way. Then you don't even from a business standpoint, you're not going to lose out patients. You're going to gain patients when you make appropriate referrals. Okay. So let us look at some of the common risk factors, red flags that happens in a clinic. Okay. I've not put everything. I put most of them. So you can be careful about it. Okay. Most common we are all afraid of is cancer. Again, remember, one of the first thing that stands out you have to think about cancer is because a lot of cancers spreads to the musculoskeletal system, prostate, breast, and others throw metastasis highly to the musculoskeletal system. Okay. So the first and foremost thing that will trigger you is previous history of cancer. So as soon as I hear previous history of cancer, am I afraid of red flag? No, the next question I ask is, hey, what kind of cancer was it? Okay. When is the recent? So what did you do? Did you finish your chemo? Did you finish radiation? Did you have surgery? Are you in contact with the oncologist? How often do you see her? When was the last scan? Was everything okay? See, those simple questions will elicit the patient will say, yeah, I see that person, this and this. She told me this and this, and I'm going to see her this and this. Have you noticed? Then comes the question, do you have any weight loss recently? No. Worsening pain. Is the pain constantly getting worse? But do you see what I put? One, the most important thing after that, I said, no response to conservative treatment. Sometimes when somebody has a history of cancer, patient over 50 years of age with new onset of pain, unexplained weight loss and night pain has never been addressed by another doctor, oncologist or something, is somebody to send immediately. But if it has been addressed, we can always watch for 1 or 2 more times, try something. Because how many times do I treat people who have had previous history of cancer for simple musculoskeletal and they get better? You get it? Because they are constantly being assessed by their cancer doctor and they are getting treatment for that. So we do not have to. And even if it is established and they're getting treatment, you can always do palliative care. That means you can make their pain better, but you wouldn't do aggressive symptoms. So this is a red flag that we don't have to worry about, but we have to be cognizant about. We need to be able to understand and make sure that we are keeping an eye on it, and we will be in constant part of the team. And this is where I would like to tell everybody, we are not, as a profession, we would lose out if we are not in the collaborative mentality. That means we are not going to say, I am alone. No, make a good rapport with all the surrounding physicians, with constant referrals, discussions. And how does somebody respect you? The respect doesn't come with degrees, trust me. The respect comes when the physicians understands that you know what you're talking and you will take care and you will not. And most importantly, he can confidently refer somebody to you that you will not hurt them and he will get a bad name of sending it to you. You understand? That is where it is important. So create this collaborative model, because as I told you to start with, you need to know when you have a limitation, you can't go any further. So you should have an immediate resource to send back. And that could be a physician locally who you trust, and send them and they can manage from there, because we do not have ability to do tests or reflect or do the rest of the stuff at that point, because our role is to screen, find it and send it. You get it? But not everyone needs to be. So this is for cancer. And remember, here also I put night pain, because another important thing I want to tell you here is night pain is the most commonest symptom that a lot of your patients will keep complaining. But if the night pain is not associated with previous history of cancer, unexplained weight loss, worsening pain, and then mechanical signs, you can wait, because inflammation also causes night pain. You understand? So you can wait. So keep that in the back of your mind. If it's unrelenting, it is not changing to conservative management 1 or 2 visits, then you got to go. And I'll tell you a simple example, couple of examples that not only us, even physicians miss. Is that one example is I have a young man, maybe in his early 30s, 30, 31 or 32, is an abomniopathy. So I asked him what happened. He's an Indian man in the local area, a very nice gentleman, an engineer by trade, and he's very highly educated guy. He said, he was very active, worked out all the time and everything. And then he went and he started getting this medial knee pain. So they saw the doctor. The doctor said, you know what, you're a young man, medial knee pain, you might have sprained as exercise, go to therapy. So he goes to therapy 2-3 times. No, this is no difference. I was able to exercise and everything. Then he goes back and the doctor says, okay, let's do an X-ray. And guess what? When they did an X-ray, they found an osteosarcoma. So what I'm saying is, it is neither the doctor, neither the therapist suspected. It's not a fault. Sometimes the non-response to conservative management in a healthy, otherwise healthy-looking young man is also this thing. That is why we said initially itself, red flags are so less prevalent. And even the other thing I forgot to tell you, so they found that the probability, there is one more slide that is coming up. Chad Cook, a very important researcher, and he has a textbook and everything if people know about him. He did a narrative review on red flag identification, and he said the predictive value of ruling out a red flag because a test is negative is absolutely poor. That means if a test comes negative for red flag, doesn't mean the person doesn't have red flag. So also remember that these are all ways in which, am I confusing you guys? What it means is that even if all the tests and all the signs here that I said here said there is no probability of red flag, they can still have a red flag. And sometimes the only way to recognize that is as you are treating, there is no change or there is worsening of the condition. That is also a red flag to refer out. So remember that doesn't mean just because, oh, I looked in all this, he doesn't have any of that, so I'm going to continue going on and on and on. So I tell everybody, I have a rational thing. 1-2 weeks, I don't see 20-30% improvement, 30% improvement, then boom. You need to get some other test, assessment, or change medication, do something. You get it? So that is important to understand here. Okay. Next, like I just told you, does the person have a human lesion? How do I find out if the person has an upper motor neuron lesion that is progressive? Simple, non-dermatomal sensory loss. Gow and stalking kind. So what is a non-dermatomal? So if L4, L5 means they have a specific dermatomal pattern. If I don't have the dermatomal pattern and it's an exclusively like says, you know what, right from this part, everything is numb from down here. Non-myotomal weakness. That means L4, L5 has specific muscles that go weak. And I don't have that. S1 and my calf is not weak. Then I have non-myotomal weakness, hyperreflexia. Positive Lhermitte sign. Lhermitte sign is when you take somebody and flex their neck, they get like an electric shock. And then positive Hoffman's. Hoffman's has poor validity. So be careful because there's a lot of times we do it routinely. Hoffman's is when you flick a finger and their whole hand jumps. You know, when you flick a finger, normally we shouldn't have anything other than that. But when I flick a finger and the whole hand jumps, that's a positive Hoffman's. It can be a sign of human lesion, but they have also proven that it is not that valid unless it is done in association with other tests. Okay, so generalized hypermobility and hypertonicity and positive Babinski sign are all signs of UMN. Plus, I also ask if the weakness is increasing, like I told you, is their gait deteriorating? Have they dropping things? Is their handwriting deteriorating? Is there having problems swallowing? So these are all signs of UMN lesion. So questioning, simple questioning, multiple questioning, watching them to walk, coming in, how they are seeing, all of these parts will make you safe from doing some harm, even if you can't help somebody. Because trust me, I believe a good PT is one who treats and makes difference in somebody about 70 to 75% of time of population. 30% we can't help. It's not in our preview. There are so many factors which can't be controlled. There are factors that we know they are there, but you still can't control, because how can you control somebody's socioeconomic if you can't really intervene? Like I told you the example, the lady at home, she has nothing. What will you do? So there'll be some places you will get stuck, which is all normal. But more importantly, like your president and Mr. Gopalakrishnan, they all said, our primary aim is, even if I can't help, I will not hurt somebody. That should be our primary motive in practice, or primary, primary understanding the way we practice. Is that I will help. I will constantly update myself to become a better therapist, but at the same time, I will not hurt anybody. Okay. So the other one, aortic aneurysm. So there's a dissecting aortic aneurysm is a sudden emergency. Do you guys know what the probability of somebody surviving once this happens? Even with surgery, the probability of survival rate is less than 50%. So it's a fast, it happens soon. And a lot of people have aortic aneurysm. So if anybody has it, don't worry, because not all of them are fatal. Because a lot of people have an aortic aneurysm that never grows in their life. They stay with it all life long and they goes away. And how do you know it's getting worse? Because if it is getting worse, you will gradually notice when you're lying supine, you will have pulsating sensation near the umbilicus. You will feel inside pulsing, your heartbeat inside your abdomen. If people are talking about it, then it's something that you can ask the patient to have it checked with his doctor, but it's not an emergency. But the emergency comes when it's sudden severe onset and they have severe abdominal pain. Thank God the pain will be so bad for us, I'm sorry, not for the patient. Thank God most of them do not show up to us. They will show up in the casualty because they have so much of pain. But just remember, if people are talking about pulsating sensation where they like supine and they've been gradually getting worse, gently tell them, okay, you know what, just tell your doctor and have it checked out. It's nothing wrong, just like that. So that is a red flag to understand. The most common, like I told you, remember the prevalence study we saw, the fractures in the spine is one of the highest red flag that we miss. And so they have found some of these in that international framework. They did a lot of research, looked through tons of data, and they came up with these things as common as things, if they are all together, to be having a higher probability of thoracic fractures, right? Fracture in the spine. What is it? History of osteoporosis. And if the person, female more than male, age greater than 70, previous history of cancer makes it worse. Severe trauma, obviously, because most severe traumas happen in the thoracolumbar region, okay? History of previous fracture. And they said thoracic pain as an entity itself. Think fracture without asking questions. It might not be a good idea. So who would you suspect? Those people with pain, lingering, with no obvious reason, trivial trauma. They said, I have even seen people who have sneezed and have thoracic compression fractures, rib fractures. So just be very, very careful applying techniques on people with history of osteoporosis, more than 70 years of age. Corticosteroid use is a big thing. You don't have to be 70 years old. If you are chronically used corticosteroids for some reason, asthma in the past. So that question, that is why if you look at that screening question that is there. So if they check it off, you're not going to throw the patient out saying it's a red flag, but that you will keep in the back of your mind and it will stop you from doing doing exercise, start doing manipulation or doing aggressive treatment. Rather, you will do more palliative treatment to see. Because do all thoracic fractures, compression fractures need to immediately go get surgery? No. If it is deteriorating, if it is in too much pain, a lot of people need kyphoplasties and other things, but others can be treated conservatively. But then you will automatically, knowing that it is a fracture, it is good to get an X-ray, confirm it, and then go from there. Sounds good? So fracture is a very important thing. Now, when we talk about fracture in other parts of the things, do we need to have everybody go and get X-rays and MRIs? It's a whole thing, and people who have attended my low back would have already known that I'm a pretty anti-MRI guy. Why? Because the study shows that there are so many people in a symptomatic population that if you do an X-ray, MRI, it will show all sorts of horrible things happening in your spine because they think it has no correlation and it could be just age-related changes that's happening. And the correlation to your present pain to what you see in the MRI might not be true. So the same way, okay, that happened. Then now somebody's coming with an acute neck pain or an acute ankle injury. Do they need an X-ray? Do you need to send them for an X-ray? You know what? You can say, I think I worked on it. I don't want to do it. Then you might have a problem. Like somebody said, it's a medical legal issue. You can say, why didn't you send it? With a simple X-ray might have ruled it out. Example, I'll give you an example. I have an orthopedic surgeon. I still work with him. Phenomenal orthopedic surgeon. He does fantastic shoulder work. and sometimes his knee post total knee replacement is 2 weeks later, the patient has no pain at all. He's that kind of a surgeon. He's a phenomenal surgeon. And he does manipulation and anesthesia on the shoulder sometimes. And his criteria is, and we have been very lucky, he'll say, do the manipulation and anesthesia, right? With the anesthesia, he will send us to physical therapy. So we can move the arm under anesthesia. So we know how much range of motion truly was achieved. And I can also show the patient who was awake now, how much really the passive range happens. And I send them back in the sling and tell them to come back when the anesthesia has gone away. The block is gone. They do cervical blocks and then brachial blocks, and then they do the manipulation and anesthesia, and they get full range of motion, and they send them in a sling till the thing comes back. This was a middle-aged 50-year-old lady who had significant adhesive capsulitis. So with adhesive capsulitis, the doctor decided to do manipulation and anesthesia. I never saw the patient before, so he decided directly to do a manipulation and anesthesia. And his protocol is anesthesia, manipulation anesthesia, go to therapy for 5 days straight. You have to move the arm 5 days straight, so that from then on you proceed with physical therapy. Okay. So on day 1, she comes and we did move it under anesthesia, showed the patient, she had full range. She said, good. And she left. Okay. And obviously we can't feel anything. So she comes next day, and everybody on manipulation and anesthesia, if you guys have seen, the next day they are horrible pain, because the first day they were under anesthesia. Second day, because the doctor has torn the capsule and everything, it's painful. It's very painful. That is why we like to show them under anesthesia, the patient, so the patient believes that the arm does move, or it's still stuck because of the pain. So the next day she comes, she's in a lot of pain. I said, okay, don't worry, we'll go under the, So I move gently. Okay. I said, okay, go cold pack, electrical stim. 2 days later, she comes back and she said, next day, because she had to come 5 days, next day she said, I haven't slept. I'm in so much pain. I said, okay, lie down. And I'm trying to pick up her hand. It's totally like rigid. It won't even move. I said, I normally don't call this orthopedic surgeon. We have an unspoken language. He sends to us and he says, these guys will take care. He doesn't even give us protocol. He says, these guys know what I do. They'll take care of it. Go. And I say the same thing. I tell him, okay, I finished. You tell him that Raghu's done. He will know what to. He will tell you whether or not. But this one, I picked up the phone and said, Dr. Krishnan, something is wrong. He said, Raghu, send directly to MRI. I'm calling the hospital. So I sent her directly to the hospital. Guess what happened? We just found out afterwards that she had a carcinoma in the head or below the neck of humerus. And the doctor had decided it's an adhesive capsulitis, and he didn't do an X-ray. If he had done the X-ray, he would have seen it. And when they put him under anesthesia, the bone is already weakened. And when he pulled on it, this adhesive capsulitis she had was triggered by the carcinoma. So it literally broke. There was a fracture. So what I'm saying is not only us, anybody. So then now we are stuck in a conundrum of where and who needs this X-ray, because technically that X-ray was not needed, because it's a straightforward adhesive capsulitis. She did not give any history. So he did the procedure. Okay. But then it ended up that she had a carcinoma, which caused a crack fracture. You understand? So eventually he had to put her back and do surgery and fix it. And she got better afterwards. She was fine, but we didn't see her. And so I kept in touch with him and he said, Raghu, she's doing well and everything is good. But what I'm saying is, now when we come into this conundrum, how do we decide who needs X-ray? So the good news is, for 2 parts of the body, we have come up with rules in Canada, where it's a socialist state. So they took up like 10,000 X-rays or something from the past, and they started looking to see how many of those fractures caught anything bad. And so they came up with a certain rule. It's a very simple rule, as you guys can see here. Are there any high risk factors? If the age is over 65, dangerous mechanism like car crash or fall off straights, and he has got numbness and tingling in both extremities, then yes, get an X-ray. No, you don't have any of this, then go ahead. Is the patient able to sit? Was it a simple road traffic accident? MVC is a motor vehicle crash. Okay. Is the patient sitting in the emergency room? Is he walking? And the pain was not immediate. It just came after some time. And there is, when I push on the midline of the cervical spine, there is no tenderness. So even if one of them is there, even one of them is there, you don't need X-ray. You can decide not to do X-ray. No, but none of them are there and the patient is not doing any of this, then you need X-ray immediately. And is the patient able to rotate neck actively? That is, if the patient is able to rotate neck 45 degrees left or right and can't do it, then take X-ray. But if they can, you don't need X-ray. Do you see how they came up with a rule? So you guys can use this. This is a very validated rule. World around use this in all emergency rooms to make a decision whether the person needs a cervical X-ray or not. Okay, that's called the Canadian C-spine rule, and it's very validated. You guys can look up for validation on this. On the same count, they came up with what is called as Ottawa ankle rules. On the Ottawa ankle rules is when, you know how common is people have ankle sprains. So does all the people with ankle sprain do need X-rays? They only need X-rays, they found out, if they are in these two regions. See this? 2 zones or 4 zones, they split it into 4 zones. So if it is A, posterior anterior tip of lateral malleolus, B, posterior anterior tip of medial malleolus, D is clavicular, and C is 5th base of 5th metatarsal, common areas of fractures, okay? And along with that, inability to bear weight, both immediately and in the emergency room. As soon as this happens, they cannot bear weight on it. So then only they need an X-ray. So these are the understanding of X-ray. So when you come to fractures, these things might help you to rule out red flags, or it helps you to send them out for X-rays. You get it? So those are for some for fractures. But when it comes to shoulders and, elbows, knees, knee, I would say, I've put something for the hip in the last, but for the knee, I look at the simple thing. If they had a major issue and right away, they cannot weight bear and they have a huge swelling, come up immediately, and they heard a big pop noise, I would surely send them for assessment, because not only assessment is essential, and they show up to you, don't think, oh, I can do rise. Yeah, you can do rise, but if it's swollen so big and the person cannot straighten the leg fully or weight bear on it, the probability that yes, it could be an ACL tear, you can treat it and everything, but the probability is that what if the joint has bleeding in it? So the doctor needs to drain it, because otherwise leaving bleeding in there is a rich environment for infection and other issues, other complications. So when you see a person like that with acute knee injury, please send them for assessment and then get them back into treatment, which you can do absolutely. Not all ACL tears need to be immediately fixed, or not all meniscus need to be fixed or done anything instantly. So you can treat it as long as you rule it out. So these are red flags when it is acute, okay? And also, if somebody comes to you with a swollen, it's warm, they are feverish, and it happens suddenly for no obvious reason, and they are young, it is warm and red, get them out, find out if they have infection or something, especially in your part of the world where tuberculosis still exists. So you should always be afraid of tuberculosis and other things. They come up slowly, especially if you see the person with poor socioeconomic level, their nutritional levels are not great. So these are the people you need to make sure that you suspect these things and will be a good candidate to get an initial assessment done and then continue with treatment. You get it? You can treat them. So this is where you will make that decision. Now, next, I told you about how cauda equina is such a problem in low back pain. In many developed world, it is one of the major reasons for medical legal issues. What is it? It is a bilateral severe pain or weakness in both lower extremities. It can start as one leg and then spread to both legs. But the most significant part is they have what is called as saddle anesthesia. What is a saddle? Saddle is the thing that you put on top of the horse to sit on it, okay? So that is the area that will sit on the saddle, isn't it? Or your motorbike seat. So that area, if they lose sensation, and they have urinary and bowel incontinence. So unless you don't ask these questions with back pain people, you would be thinking this is an acute disc or something, and I'm going to treat it this way. And these people are generally, look at this, they are less than 50 years of age and they can be obese. Okay. And the most important thing is here. And then again, it's a very sensitive issue to ask. How do you test it? There is also the anal sphincter can be weak, loss of tone, but they have come up with now, and they said in that article I read that even in developed world, they have found that is not an immediate need to be checked on. So the most important, easiest thing you do is to pinprick or light sensation test in this saddle area. Remember, it is a very sensitive issue. Please have a chaperone, somebody with them, ask their consent appropriately and respect their privacy, give them a private room and test the sensation. And if you find it, this is an immediate cause for referral because there is an acute compression of the cauda equina, which can be easily relieved and reversed. That is why all these medical legal cases, you understand, it's not like a, oh, even if I didn't do something, nothing won't happen. No, this is something easily reversible with surgical and other interventions or with medical intervention. So you should be referring these people if you get them. So remember, severe pain or weakness in lower extremities, saddle pain and anesthesia. So asking questions, tell me where you're, they say, oh, my back kills me. Where else do you have? And, you know, people are hesitant to say that their groin hurts or right in between their legs, it is hurting or I can't feel it. And so sometimes, you know, people don't even think about it. I ask a easy question. I say, when after you go toileting, when you wipe or you clean, have you noticed any difference that you're not feeling there, down there? They say, no, I'm okay. So then you can be careful about that. So ask these questions, you know, it is very important and it's a very important red flag to check on. Next is vascular claudication. Obviously, you know, this is a vascular issue. And one other thing is history of cardiovascular disease. Who doesn't have it? The pain in the calf with activity relieved with rest. A good symptom can be one foot is colder than the other. And again, see, this is the most important thing here. Symptom cannot be provoked with mechanical examination of the lower back. Okay. So again, the non-mechanical component is a giveaway here. So think about this too. Acute spondylolisthesis. This is an young individual who does repetitive hyperextension injury, like a dancer who's doing extreme dancing or gymnast or football, you know, where they're taking a long kick, they're trying to do a long kick, or, you know, somebody who's like trying to play cricket and taking a long shot, leaning back to hit the shot, that can get sudden severe bilateral sciatica occur during athletic activity. And it's pain with extension. And an easy way to rule that out is prone with passive bilateral hip extension. So you put them prone and gently try to do bilateral hip extension passively. And if it causes severe pain, this is mainly extension pain. So you be very careful. They're saying easily do prone with passive. This person is in so much pain with extension, they will hate you putting them into extension. So just be careful. Make sure. Think of this in an young adult who's a sports person. Okay. Obviously, this person also, to a great extent, you won't see them. They will have this sharp intermittent pain. 90% of them who have had it, I have known. I've never caught one in the clinic because most of them automatically go to the emergency room because the pain is so much. Okay. This next one I'm going to show is a critical one. Now that you guys are seeing a spurt of physical activity everywhere, all young adults want to look good, stay in shape. So they are doing exercises. And to a great extent, there are some of our PTs out. There is one Murugavel Manikavasagam in Brunei and Sudarshan out here in Canada. All these guys are already been talking about what is called as exercise addiction. You know, some people cannot just stop exercising. They want to keep on exercising more and more and more. So that can end up with too much of exercising, can end up with stress fractures. It can happen commonly in women in sacral stress fractures, and also foot can have stress fractures, shin splints to great extent, also a small form of early form of kind of stress fracturing. So be careful. How do you find them? You know, this is a young adult athlete. I don't know whether you guys have heard of the concept of female athletic triad, they call it. That is where the female athlete, increased level of vigorous repetitive athletic activity, pain involves the buttock, pain reproduced with athletic activities, especially with weight bearing kind of activity. And most of these athletes also have eating disorders. They don't eat well because that is the triad. It comes with the vigorous activity, they have dietary insufficiency, and the most important, because of all this, there becomes significant hormonal imbalances causing menstrual irregularities. So you have to ask, see, that is why those questions were there in the review of systems. If there is menstrual irregularities, along with dietary insufficiency, they're not eating well. You can see them, they look pale, they don't look healthy, fit, they look like they keep on going. I'll give you an example. I had a lady, this is a serious yellow flag too, because it's a psychological issue. She would die. She had this acute thoracic pain, which a doctor can give an injection and the pain comes down. Okay, the pain comes down, but then it comes back. So he sends to therapy. How much injections can he keep giving in the spine? And if you take a detailed history, you know what she tells me? She tells me that she has to run. Has is the question. Has is the word here. She has to run 6 miles every day. She will make time, whether it's hurting or not. She says, I cannot stop running. She will not stop. Not any day, 7 days a week. I even called the physician and said, look, this is an issue. Tell her. No, she stopped seeing me. What can you do? You know what I mean? So how would you keep on running 6 to 7 days a week with pain? It's bothering you so much and you're not eating well. So this is a very important thing, especially when people are so pumped up that they want to achieve in athletics, or they are so pumped up to look good, they overdo it sometimes. So you got to be careful when you have this athlete you're trying to treat. They have a buttock pain, it's a female, and you see them, they're extremely thin, and you can notice that they're not eating, or they have eating disorders where they have bulimia, where they're throwing up. So you can see them in their teeth will not look good with that. Read up more on that issue. And people, I heard that you have a big section of women's section. The women's section, it is a very interesting topic for the women's section to look through and read and dig into more of this and find those young ladies there and help them. So they also have generally a lot of previous stress fractures, and non-responsiveness to previous treatment should make you suspect of this condition. Okay. Obviously, stomach issues. Again, this is the most important thing. If any gastrointestinal reason for pain, symptom cannot be provoked with mechanical examination of lower back. Pain can be relieved by further intake of food. Occurs after eating in upper lumbar area, L1, L2. So some of these things are common sense, So just ask, questioning again and again. What does it say? Question, talk. The more you ask, the review of system should trigger your answers, and you further question them, and then you make a decision. Do you have to immediately send them, or can you do something about it? I think you guys are all well versed with this. Forget, I just put this as ankylosing spondylitis. You can use the same thing for rheumatoid arthritis, systemic lupus erythematosus, psoriatic arthropathy, all sorts of reactive spondyloarthropathies, whether they're rheumatoid positive, negative, we don't need to go there. We need to have to recognize if it is an acute. They have not seen the doctor, and there is a widespread axial pain in the extremities and fingers in rheumatoid. And in ankylosing spondylitis, is a middle-aged guy. Pain starts with sacroiliac joint. Okay, bilateral limitation. See, and range of motion is constantly decreasing, and also they get the classic bent over posture. Morning stiffness sustains for a long time. Okay, and what is one giveaway thing that I didn't put in here is that loss of rib excursion, a decrease in thoracic rib expansion is a classic sign of ankylosing spondylitis. Also, it's generally a young male complaining of sacroiliac pain that is not decreasing with increasing decline in range of motion. Could be a suspect of ankylosing. We catch them all the time, and me and my colleague have found quite a bit of them, and we have called the doctor, told them to go see the doctors. They have been diagnosed and they are put on, nowadays they have fantastic disease modifying medication which slows and arrests the progress of ankylosing spondylitis, and they live decent lives comfortably without the progression of the disease. So be careful, go through, take this opportunity today, go back and read up on your spondyloarthropathies or your new rheumatology topics, so that you'll be able to rule them out as soon as you see them. Why is it so important? Because please remember, and also please remember, these people, if they have not been diagnosed and treated by a rheumatologist or primary doctor with disease modifying disease, every day they have this disease, it is going and eating on all their soft tissue. It is destroying their joint structure. And unfortunately, I am from an era, maybe most of you are not, but I'm from an era where I saw in the 80s rheumatoid arthritis that is not controlled, don't see patients, young women. I still remember this vivid picture of about a 30-year-old young mother. She already had a 12-year-old daughter and husband who had to go to work. And she was so she had so much involvement rheumatoid that was never treated, significant deformities. Even she couldn't open her T&J. And she was constantly living on ibuprofen, and which was tearing up her stomach. And there was no end to it. And it was causing all sorts of havoc on the daughter, son, her husband. The family was shattering. I don't know how long she lasted, but what I'm saying is the earlier you can catch, you're doing a great help to the patient by sending them, having them tell them the importance of medication, stay on medication. So because joint protection and prevention of destruction of the joint is the key element. And nowadays they have fantastic medication, which is not no hit or miss, but they have disease modifying medication nowadays that can help these people significantly. So go in, pull out your books and read about some spondyloarthropathies, okay? Now, last but not the least, cardiac. A lot of cardiac, straightforward, they have chest pain, swelling. Okay, they will all go to ER, everybody knows that. Why is it so important I'm talking about it? I don't know whether we are blessed or not blessed, but Asian Indians have now been categorized as one of the highest risk factors for cardiovascular disease. And that is why we see younger and younger people dying early of cardiovascular diseases. So identifying them, you might be helping somebody to identify this. Why is it being talked about to a physical therapist? Is because it is so common that a lot of atypical cardiac pain just happens in cervical and thoracic region and left upper extremity, which can easily be mistaken for cervical radiculopathy. Okay, I'll tell you an example. It happened to me recently, about 3 months ago. This was an older gentleman, a Pakistani gentleman who was a very respected man. He was a respected engineer. He worked in a big firm. He was closer to his retirement. And somebody referred him, told him, Raghu, I said, Raghu bhai, I heard about you. I want to, and I have to tell you guys, yes, we are bye here. We don't have any fights here. India, Pakistanis. My neighbor is a Pakistani. So he come by Raghu bhai, they talk to me about you, or they want me to come and check on you. Okay, I said, okay, what's going on? So he said, I have this significant upper thoracic pain that goes down to my arm and a little bit into the middle of my back, not that much to the arm, mostly to this. And he comes with this classic head forward. He was stuck like this. And he has pretty much that much movement. And he works all day like this. And he said, oh man, it kills me. So I did all the assessment and red flags. No, I'm healthy. I see the doctor regularly. I don't have any major issues. He goes to work regularly. He even comes from work to therapy, has to adjust his time, goes to work regularly, drives about 30 miles to work, comes back 30 miles, and he was fine. And so we tried everything, changed posture, thought it was some radiculopathy, did some traction, did some manual therapy. 6 visits, 7 visits, he would say, oh, it felt great, but then he'll come back and say, no, you know what, it's still annoying. Something clicked to me. I said, you know what, something doesn't sound right. When is the last time? He said, no, I've had a physical, but was not an intense one. So I said, I suspect something. Just go to your primary doctor and go back and ask him, tell him that I'm suspecting that it is not of musculoskeletal origin. And he left. Okay, I forgot, I was busy, nothing. So here comes 2 weeks later. So they told me front office, telling me, Raghu, this gentleman is on the phone. Generally Indians here have a tendency that they'll pick up the phone and say, I know Raghu, I want to talk to him now. I won't leave a patient and we'll say, take a message. And something told me I should talk to him. So I picked up the phone and I said, hey, what's happening? He said, Raghu, guess where I am? I said, where? He said, I'm right outside in recovery after cardiac surgery. They found almost all his arteries were blocked. He was in the verge of an imminent cardiovascular incident. So I'm not saying I found it, it's just a hunch. But what I'm trying to impress upon you is I was not good enough to send him off on the first time. But this can happen. That is what I want you to understand. Keep it in the back of your mind. And he came back to see me after 3 weeks. He said, all his pain is gone. After his bypass procedure, he has just sternal pain from surgery, but all his upper back, he's still at the posture, but his upper back pain is all gone. All that annoying, aching pain he had is gone. So that was classically a cardiac pain. So what I'm saying is when something, so how did I make this decision? Even though I did try all the manual therapy and everything, I made a decision. It's not making a change. It doesn't feel right. Something is going on. Go have an assessment done. You get it? So he just did he said the doc did an EKG and he said, okay, let's send you to the hospital. Immediately this was followed up with a stress. And the same day they did a cath and they found, no, you can't finish with the cath. You have to convert it into a full bypass, and they did a bypass procedure. And he was very happy. He's back to work. He came back to thank me and he left. So what I'm saying is, see, I didn't do anything for him excepting doing the referral. It again helps you in one way, but at the same time, you have also helped somebody to look at it laterally. So rather than keep going, if you can't make change, do understand that atypical cardiac pain can mimic musculoskeletal disorders. Okay, so be careful about that. Last but not the least, infections. Okay, infections are very, very real, but you do notice that the prevalence of that was very, very low in Western population. But in your neck of the woods, be cognizant of tuberculosis. I have practiced in India. Don't guess me that I worked only in America. I've worked in India for 7 years. I've done all sorts of ICUs, everything. So I've seen tons of tuberculosis. I've treated lots of Carey spine, sacroiliac joint fused because of tuberculosis. I have seen knees fused because of tuberculosis. So tuberculosis is a thing. And I hope by now, 20 years later, you guys are not seeing as much as I used to see, but it's still a very good possibility, especially in lower social economic group where the nutrition is low, and people like that might have higher probability of infection. So be careful when you treat that population and be always cognizant. Some of the things that you can lead you towards infection is pain, warmth, erythema, swelling, fever, night pain, recent history of surgery, immunosuppression. Okay, now that happens even here. Here now the major cause of infection is from, remember I talked about disease modifying medication for rheumatoid arthritis and others. There are a series of medications now that suppresses the immune system and makes rheumatoid better, not by trying to treat the inflammation it caused, but rather by, and you guys have it there too. I don't know the names of medication in India. I have not used, I'm out of that loop, but you guys can look at it. They got disease modifying medications in rheumatology. So for ankylosing spondylitis, for rheumatoid and other diseases, they do give them, because in olden days, the only situation to do was corticosteroids, which had so much side effects. So now they can do the disease modifying, and a lot of patients do really well that their disease gets modified, and there is an arrest, but they have to stay on this. But one of the side effects is what? Because of the immunosuppression, they can have higher probability of infection. So these people have to be careful when they go for any procedure. So they stop this immunosuppression at least 2 weeks before they have a surgery or something. And when they finish the surgery and everything is healed, then they go back on the immunosuppression medication again. You understand? So please note all that in the history. Ask again, ask. Talking is the greatest tool we have. And I think we are all gifted with the gift of gabbing. We should use it in a positive way to be able to make changes, okay? And they also found intravenous drug use is another. People who are drug addicts can have more stuff, all right? Or people who need to get in a routine basis medication intravenously can also be a problem. Well, last but not least, just like I just informed you about in lower social economic groups where the cleanliness and nutritional levels are low, are also higher vulnerability to infection. So be cognizant of the fact of infection. Now, like I told you, if anything around the hip, you see these things happening, it's a high impact trauma, straight away you have to think, get something ruled out. High impact trauma, car crash, jumped off a building, got hit by an auto rickshaw. All of these things, high impact trauma. That even low impact trauma with known osteoporosis. But these classical signs here will make you understand that it is not our purview. We have to send them out before anything can be done. What is it? If you see somebody who had an injury and had a shortening of the leg, and the leg is laying in external rotation, and sudden limitation of mobility, inability to weight bear, should be sent out. I wish we had rules like the Canadian C-spine rule and the Ottawa rules for hip, knee, ankle, foot, hip, knee, and for extremities, but there isn't. So for right now, we have to use things like this, okay? I would go ahead with any type of trauma around shoulder and elbow, especially they say with elbow with children, be very, very careful, not because of anything, but there can be growing problems and stuff like that. So always get an opinion, send out for assessment with radiographs and other stuff before you continue treatment rather than doing it blindly, okay? So that's for the hip. Last but not the least, I don't know how common it is. When we finish this, you guys can comment about it, because I do want to stay and I want you guys to ask me and talk about it, because I want to understand also how it is in India, because DVT or deep vein thrombosis is a huge problem in the West. I just had somebody, and a young, like 27-year-old guy who went through ACL surgery. Within the first week, he had a deep vein thrombosis. I didn't catch it before he came to me itself. They caught it already in the hospital. He had a deep vein thrombosis. It's so common in the Caucasian population. So how did we know before? I don't know whether you guys all studied about the Homan sign, where you press on the calf. If it's hurting, it's DVT. But it's such an unreliable sign. They came up with what is called as Wells criteria. Okay. So in the Wells criteria, you have to, when you have pain, 50% of the patient, redness and swelling, and you have all these three, and if you can do this score here, do you see these questions? You answer the questions yourself. If it is less than 2 points, DVT is unlikely. If it is greater than or equal to 2 points, DVT is likely. As simple as that. And it's quite a bit validated. And there is a tool available online to do it online for you directly, or you can do it yourself in your mind. You know, I keep it in my mind and I will check on it, boom, 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 boom. Okay, if it goes more than 2, call the doctor, send it out immediately, you know. So they need to have a Doppler done. And again, this is a serious condition. Why? Because this deep vein thrombus can dislodge and become a pulmonary thrombosis, leading to pulmonary embolism. So you can have not a pulmonary thrombus, sorry. This thrombus can dislodge and become a pulmonary embolism, which is a very fatal condition, which has to be treated as soon as possible. Not very fatal. I know people who do very well, but they need to be treated. They have excellent medication for it. They all get treated like there is nothing happening. Now here DVT is like they used to put filters and stuff. Now they don't even do that. They just put them on medication. They used to do heparin. They don't even do heparin now because they have phenomenal medication other than that. They just ask them to stay on it for 6 weeks. Some people 6 months, some people for life. I don't know what the criteria is. They do it. Okay. So DVT is a reality, especially in post-operative, elderly people who have been bedridden. That is what clearly you look at these questions, you will be able to answer this. So keep this with you or read it and keep it in your mind. That will allow you to make the decision to immediately send them out for the thing. Now, where does DVT happen the most commonly? In the lower extremity, isn't it? But can it happen in the upper extremity? Yes, it can. So what we need to see here is lower and upper extremity can also happen, but upper extremity is a rarity. And they say you can find them commonly in people who have had a catheter in situ. See, there are some people here, I don't know whether they do it there. Here they put catheters indwelling for somebody going through chemotherapy and other things. They might have an indwelling catheter, which they go intermittently and get medicine and stuff. They have found that those people are higher vulnerability to DVT, but we don't have a criteria or anything to assess that. Okay. So just keep in mind, because technology is growing, it's coming everywhere. So if somebody is getting acute treatment and you see them suddenly with swollen arm and painful and redness, you might want to consider sending them out. It could be an infection, cellulitis starting, or a deep vein thrombosis. So you will do them a benefit by sending them out for a referral. Sounds good? So I have tried to cover as many as I can, but there are more. So read more. I give you an idea. I'll give you some more resources for that. Okay. But in the meantime, think about this. This is what Chad Cook said. See, clinical tests for red flag do not exhibit low likelihood ratios, negative likelihood ratios, suggesting that they failed to rule out a red flag when a negative finding is present with the test. So when there is like that, red flag findings are more closely affiliated with prognosis than they do actual serious pathology such as cancer fracture. Although low back pain clinical practice endorses assessing red flag, only a few outline which findings are useful for clinical practice. So what he is trying to say is, don't jump to conclusions based on that, but keep them in the back of your mind, keep doing it, and based on your treatment, and if there is no response and stuff like that, and if you find I have given you things that are serious and immediate, try to refer immediately. But you wait and watch. Always when you have the original review of systems, you see these things that should stay in your mind, and you should be cognizant of watching and make the referral as soon as possible. Okay. And I will tell you the take home for me is that if something sounds non-mechanical, it is rigid all over, or I can move fully, but I'm still in full pain, both of them are not good signs, because pure musculoskeletal will always have a pattern of some way or the other. Okay. Neck or back or anything. And you have rules for cervical and ankle that can allow you to make the decision. And who can get osteoporosis. So what the prevalences are now. So keep all these things, go back towards what I told you, keep reading it and see if you can help with this. And also remember, all these people I put in here is all their work. And that is why they have all been cited clearly, and they have been cited so that you can go get those referrals from there. Okay. And most of those things without citation come from that international framework. Okay. And if it is not from there, it has been cited separately. Okay. But now people are saying, oh my God, he came in and confused. Where can I do something structured and I can do anything? My mentor, Deepak Sebastian, has a phenomenal book published specifically for India, and it's published by JP Publications. This book is written in very simple terms for the physiotherapist, okay, of every region, in which you can not only go through red flags, yellow flag, not too much of yellow flags, but red flags, medication interactions, how to understand all lab tests, analysis, red flags, and simple assessments for every system separately, one by one. And he has created his own system of looking through that. If you can use that, this book is a great resource. It's available with JP Publications. If you guys are interested, you can read on that too. Okay. Now that is something about red flags. So what is a question of red flags? Technically, red flag means stop everything and send out. But we know that that's not true, but the word still exists about red flag. So be cautious. But yellow flags are more or less just cautious. So what are yellow flags? Yellow flags are psychological prognostic factors for the development of disability following the onset of musculoskeletal pain. What does that mean? That means that even if I'm treating somebody, if they have heightened psychological issues, then their prognosis of improving is bad, leading to disability. So your ability to identify these factors will help you in treatment. So how do you assess it? What are all these problems that we are talking about? How do I know that there is problems with this person psychologically? There is a simple way in which we can find out. These people generally have widespread pain. That means they're not going to come and say, I have back pain on one side or hip pain on one side. They are going to say, I have pain here. Sometimes it's in my shoulder, sometimes in my back, sometimes in the leg. Pain does not follow anatomical pattern. There is high psychological distress, and they come in and they're anxious. They're like, oh my God, why is this happening to me? I don't know, something is wrong. And nobody can help me. That kind of high psychological distress, and pain disproportionate to provocation and easing test. That means, see, like I told you before, if somebody was in flexion, think they had flexion, right rotation was painful in the spine. So I can take them to that position. They say, oh, it hurts. Then I can take them into extension and left rotation, and it should really ease it. So that is a provocation and alleviation test. That's one of the ways in which we assess and decide, oh, this is what is happening. And I can try and work to improve the right rotation, and then see if both ways are easy to do it. But these people have none of that. plus on top of it, we have hypersensitive. We are hypersensitive to touch and cold. In fact, Deepak, Sebastian and us, we used to work together. And that time, I don't know how many of you are Tamil Nadu and other places. We used to have an actress, ex-actress called Silk Smita. She was a like a dance vampish actress who used to do all these dances. So we used to call it a silk sign in our clinic. What was a silk sign? So if you made somebody sit and they said I had a back pain, I barely put my finger on them, they'll go do that right away. Then we know this is an exaggerated response, which is not even right to somebody to touch, shouldn't cause that much pain, should it? But they really are feeling it. So that is hypersensitivity to light touch. And specifically these people, I don't know how many of you use cold in your practice, but if you use cold packs, have you noticed some people will say, oh my God, you did cold pack yesterday and it got horribly bad after that. These people with higher psychological things and increased central sensitivity end up having hypersensitivity to touch and cold. When you see these people, you should suspect psychological disorders and think about it. Even though they have biological reasons for their problem, it is being complicated by the psychological, or the psychological is hindering the improvement of the biological. So if you are able to modify, so sometimes nowadays they are even calling it psychologically informed physical therapy. So if you can inform, educate, pain education and other educations can be provided, then the treatment is much more effective. We do this very, very effectively. In fact, we have been in our practice, a lot of people have say that you guys talk the people out of pain, because a lot of times it is anxiety and your ability to understand these things and find these people and alleviate their anxieties, alleviate their fears, then they will move better and they will start doing better and their problems will decrease. You understand? So what are all the things that generally happens with these people? They can have all of these: depression, trait anxiety, anger, fear avoidance, belief for physical activity, fear avoidance, belief for work. Okay. Here I have to say this. We have seen this pattern happen in our practice like 3 or 5 times now, that when youngsters who come from India, who have lived their lives in India, they come on like computer professionals, very common. They come to work in America and they come and see us. They say, sir, I had this back pain 5 years ago and I went to this practitioner, I don't know if it's a physio, they are the doctor. They told him, you know what, from now on, you should not bend. Now, my question is, if I can't bend, how do I live? I'm 5'11", so something falls on the ground, I don't pick it up. So the answer is, even McKenzie, who talked extension, said that after 3 days of extension, you should start flexing. As soon as the pain centralizes, you should start flexing. In the 1970s, why are we still telling people that they shouldn't bend? So then this person has a fear avoidance belief where he thinks that if he bends, he's going to hurt. So he's pushing himself. He's sitting like this all day long. So his pain is simply facet pain from overloading with no relief. So that's a fear avoidance belief or work. And somebody said that, oh, you should not bend at work, or you should not turn at work. You should be sitting in a certain kind of chair. And they said, sir, they're not giving me that chair. So my back is killing me. Then pain catastrophe. That means if you have this much pain, you're like, oh my God, my pain is this much, I can't tolerate it. Pain catastrophe, pain-related fear of movement, pain-related anxiety, pain self-efficacy, rehabilitation self-efficacy. That means some people don't believe rehab is working or it will work. They say, I'm in pain. Why are they not giving me medicine or operate it and take it out? Why are they asking me to do rehab? And then at the end of it, remember, at a certain age group, and we have some amounts of achiness, stiffness, pain, everything comes on. I'm 55. I know that is a true issue. We all are going to have that. So people are sometimes telling you, I'm not better at all. Then I ask a question. People will come and ask, I'll treat somebody, and they'll come next day and say, how's your pain? I'm okay. I'm still having pain. So I asked them then again, now tell me, is it the same pain you had yesterday? I was, oh, no, that is not there. I'm having pain somewhere else. So is that the same pain? No, then you have to educate them and tell them, look, this is not the same pain, it's moving. So acceptance, coping behavior is also affected. So there are so many factors, and it's too little a time to be in this to tell you, but be aware that there are so many of these psychological issues that needs to be addressed. Now, We need something. Okay, you said easily psychological issues. How do I treat it? I don't know. How do I find it? Good question. So we have some tools for it. See, I'm going to go like this first. In my practice, this is what we have used for a long time. This is called the START tool, but this is for, as it says clearly, it is for the back. And the START people, that is from this Jonathan Hill in Keele University in UK, is the one who came up with this. It's accepted. See how old that is. It's accepted as a very good tool to rule out people for referral. That means you can refer this person out to a psychology or a mental health professional, because if their psychological issues are so bad that you cannot treat them physically or medically, they need psychological counseling. This tool was used, okay? And it gives you a good idea of how to do it. It's a simple tool. It's only got 9 questions. Do you see that? So I give all my patients get this. If you have a back pain, all our patients in our clinic get it. How do you score it? You score all of them. See, you get 1 point for agree, 0 for disagree. Okay. And also the 9th question has 0 zeros and 1. All right. So how do you score it? If the score is less than 3 or less, there is a low risk of psychological problems. You can treat them effectively. And if they have 4 or more, so if you say 4 of them are agree, then you take a sub-score of 5 to 9 only. And if the 5 to 9 is 3 or less, it's medium risk. If it's 4 or more, it's high risk. Technically, according to Keele people, the high risk people have to be treated by mental health professionals, but medium and low risk can be treated by you. But again, this only gives us a general idea that this person has psychological issues going on. So thank you all for making me do this program, because that's when I started researching and I found that OSPRO, let me talk about this later. Oh, what the heck did I do? So that's when OSPRO, remember we talked of OSPRO before. So the OSPRO came up with a second tool, which is called OSPRO Yellow Flag Assessment. So that's called OSPRO YF, they call it, if you want to search for it. So this is a 23. So they did a lot of questions like before, and eventually they ended up with 23 questions. Okay, those 23 questions, they came up, and with this 23 questions, they found out, oh, sorry, this is not 23 questions. This is only 17. Review of system was 23. You guys know that I'm not using it. So I'm not going to lie to you, but it's a great tool from what I've read and researched yesterday and day before. It is a 17-item tool, which can also be tested with just 10 items and 7 items, the way they tell you. And they have a good ability to identifying yellow flags, up to 85% in the 17, 81% in 10 items, and 75% in 7 items. And the good part about this tool is it can separately test vulnerability in negative mood, fear avoidance, and decrease in positive things that will make your pain go away. So you have separate tools. So when the person does this tool, let's take a look at the tool. See how it says this is negative mood domain, this is fear avoidance domain, and positive affect domain. So here, if the person does this, and how do you score it? They say the higher the score on all of these up to here, higher the score is bad. The lower the score on this one is better. Oh, no, I'm sorry. No, you're correct. It's only this last one. See, this last one alone, you score it up opposite, but the rest all, if the score is higher. So it is, if the score is higher, then you can say that these people have positive affect. See, it says the question is, it's okay to experience pain. It's okay to experience pain, isn't it? Because pain is safe. Pain is a way your body avoids you from getting hurt more. But you need to make it better and gradually get better. Don't go into a mood of saying that, oh my God, I should not have pain. You know how many people have anger issues? You know, people come to me and they say, why should I have pain? I shouldn't have pain. Then I ask them a question, why can't you have pain? You're a human being, isn't it? Is there any reason why you shouldn't have pain? What we are looking at is you can have pain. How can I relieve the pain? You don't have to be angry, because with that anger, it's only a negative and it's not going to help you in any positive way, isn't it? So our ability to understand where it remains. So if you do it on day one, you can say, okay, this person is a pretty negative person. See, it says clearly here, I'm a hot-headed person. So if the person comes in and suddenly starts getting, no, why are you asking me this? What is this? We don't want to react the same way. We understand this person, okay, he's got a psychological issue. I'll talk to him slowly, then get his trust. An example, somebody walked in yesterday, day before, one of our home care therapists who's a good friend of mine. He calls and says, Raghu, this person is post total knee. He has a lot of pain issues. I'm going to refer it to you. Please take him in within 1 or 2 days. And it's a favor. I said, sure. So we put him in. He walks in. As soon as he walks in, obviously, like everywhere else, finance is the issue. So the front office said, hey, you know that you have a $30 copay. See, the copays are, I don't want to go into insurance. It's something that the insurance will pay only a certain amount. The patient has to pay a certain amount on the day of the visit. So it's getting worse in the United States. So people are struggling with that. So the person said, oh my God, I don't want to pay 50. I didn't know this. This is a bad idea. I'm going to leave. So I said, hold on, gentlemen. Wait a minute. Come on in. Let's sit down and talk. Then I talked to him. I said, look, your leg is swollen. That's your insurance. That's what you paid for. You have to get the treatment. You have got your surgery done. What are you going to do? He said, yeah, what you're saying is right. And he apologized profusely. I said, it's a sudden, all the pain, the irritation on top of it when I heard this. So ability to perceive the psychological issue calms this person down. And if it not, this person would have walked away and he would have always had a negative connotation that he did not get it. And he will wait later. He might make a decision later. By then, he has gotten worse and he was not moving his leg. He would have gotten stiff. The doctor would have done a manipulation and it will all end up in a bad response, isn't it? So understanding the psychological issue and work on it. And this, I think this tool really breaks it down beautifully. So you can look at it and then make decisions. And Vishal and others who attended my low back will tell you how you can use tools that we show you about how the MRIs need not be all true, how other things, it's okay to have pain, it's okay to move, why is it not anyway, and how knowledgeable you are that you won't lead them to problem issues. So you talk, you explain, then you see how comfortable they get. Like I just gave you the example of the lady with the cancer she had. And when I explained to her everything, she's more than happy that same day. And then 2 days later, her negative attitude was so bad. One day, she was like so depressed. She's like, a cancer, why is it going on? Then I asked her, look, what are you going to do? Okay, you're cancer, you did everything. You are thinking that your mortality is coming soon and you might die or something. We all are going to. But what is the point in going to that point until that point and keep on being negative? Can't we be positive? Can't we enjoy this part of time? Can't we enjoy the ride? And a few minutes, I spent 5 minutes asking her some philosophical thoughts. She was very happy. She said, yeah, it makes all the sense. I will try this. Let me do the exercise. See how it changed. So I think that came to us through our practice, and it was hit and miss, and it was also blessings that we are able to perceive it ourselves and we are able to explain it. But how much more powerful would I have been if I had this tool and I looked through it? And I said, even before we go into the room, when you have this tool and you read through it, you said, oh, I'm going to see a person who's kind of negative about it. I'm looking at a person who's afraid of certain things. Then let me do a thorough evaluation and address the psychological issues. And I have not even touched the socioeconomic issue. So that also, if you can tackle to some extent, think how much better results you can get. And that is what we want to try and emphasize. And I hope I've taken a little extra time than we promised, but I hope this gives an insight. I'm not saying it is all the finality. It gives an insight into how we have to define. And what is the one take home I want you to do is thorough evaluation. And what do I mean by thorough evaluation? Evaluation starts from reading the papers they wrote. So they're going to do a review of system sheet, which already gave us idea about red flags. Then that is going to trigger you to think about the prevalence. And then you're going to use your clinical judgment to rule out the red flags. So you have ideas of some of the common red flags. And from there, you will also have another form they had done, the OSPRO Y assessment tool, which will also give you an idea where they have a problem and telling you, I'm going to start using the OSPRO Y assessment form as soon as possible, so that I will start making more faster decision. I don't have to wait 2 or 3 sessions with them before I understand, oh, they are afraid of doing this. Okay. And then I can make more judgment calls where I can make better decisions on what exercise I will do, what manual therapy. Because I'll tell you a simple example. Manual therapy on a lot of psychological high yellow flags. In fact, a lot of the prediction rules, if you look at for manipulation, will say that a person with FABQ score above 15 don't manipulate. So I didn't even touch the FABQ because it is so redundant looking at this tool, that FABQ is a redundant tool, which is a fear-based avoidance. It only tracks the fear-based avoidance of movement, but this tracks the fear-based avoidance, the negative mood domain, and the positive effect domain. So I think this is a better tool to use. And from here, pick up those questions. Pick up from there, use it in context with what the patient is telling you. This is why a first dialogue, a first history, first talk with the patient, constant questions, put more questions than you. They are not going to tell you that because they think you don't need to know. A lot of patients think he's a physiotherapist, he doesn't need to know. That I'll tell the doctor. You understand? He's not a physio. I'm here for physio for back pain. Let him fix my back pain. But they don't understand the back pain can be related to your thing. I have a right shoulder pain. What if it was a gallbladder pain? Gallbladder pain will cause right shoulder pain. You get it? So you have to make sure to get a good history. So talk, analyze, think, and you will be a better therapist. And I hope this has given you an insight into what we do. And then catch us up and let us have a few sessions. And I don't know who's going to take over. And if you guys have questions, ask me, and I'm more than happy to answer.
Thank you, sir. Really, that was an awesome class. It is time to discuss. You can ask any relevant questions regarding today's class.
If you guys have no access to the OSPRO tool, I might be able to send one to Vishal. I'll send one copy to you. Guys can, or you can look up online too. If you guys don't get it online, Vishal can call me and I can send it to him.
Yes, sir. Yes, sir. I'll do the needful.
Okay.
I think
There are some questions in the chat box. Yeah.
Go ahead, my friend.
Madam, go ahead with the questions.
Are there any questions?
Yes, sir. 1 second. I'll read out for you.
Sure. You know what? I don't know if I can see it too.
Yeah, you can also.
Where is it?
Could you repeat the 2 types of OSPRO tool that you will send it to me now, so I can.
Yeah, the 2 types of OSPRO tool is the OSPRO ROS, which is OSPRO Review of Systems. So you can search on Google as OSPRO. OSPRO ROS.
Okay.
And OSPRO YF, which is yellow flags.
Okay, and then the other questions coming. 1 minute. Sir, in UML lesion, is there hypotonicity?
Sometimes you can have hypotonicity also. He's right. Hypertonicity is the most common one.
Yeah. Then any inputs to differentiate a neuropathy pain or due to any nutritional deficiencies? If any articles, please share to us, sir. Like this one question.
Okay, but neuropathy is a totally different concept. How would I again and again, I'm going to tell you neuropathy, the easy way to know that it's going to be bilateral and the symptoms are more or less like burning because it's a neural pain. And secondly, you will notice that there will be no mechanical signs, but there will be more sensory signs,
Fine.
Okay, and the nutritional, I'm not good at it because I don't do it. And That's some topic that what I don't know, I cannot comment on. But if I find something, I'll be more than happy to forward it.
Fine. How can we manage time-taking detailed assessments? One question is there.
Yeah, very good question, because for us time is money also here. But the problem is you have to thank God for us. Our insurance payments they do pay for one evaluation. So we do like 1 hour fully we block off for a patient for a new evaluation, while the treatment sessions go to half an hour with us not being there for electrical stimulation or something for another 15 to. So generally they are here in the clinic for an hour, but we see them for half an hour. But evaluations are treated for a whole hour. And I'll tell you something, if you do a good interview, a lot of your objective testing as you grow and you keep on doing it continuously, it goes fast. You will see. And again, there is a whole class on clinical reasoning. If you take it in clinical reasoning, we say, as you grow older and older and you do this more and more, you go to a point, what is called as, they call it, there is a term for it. The term is, you're automatic. It is called pattern recognition. In clinical reasoning, it is about pattern recognition. You recognize a pattern, and as soon as you pattern, it is called metacognition occurs. So you have cognition, isn't it? How do you have cognition? Cognition is when you do 10 questions and each question answer, okay, if this answer is positive, this answer is positive, then eventually this is the answer, isn't it? That is the cognition. But they find that you do not have to go through 10 questions to receive to the answer. As you keep on practicing more and more, that is called as metacognition. You automatically jump to that level. So they have proven that. So if you constantly practice and you're practicing in a structured manner, if you do it over and over again, you don't have to start from the basic. You can jump to the level 5 or 7 right away with pattern recognition. So that is how you manage time. And that is why I keep telling over and over, it is practice, 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 practice. Okay. So that's why they call it a physical therapy practice. It is, you have to practice all the time.
So next question, it is coming. How many Bacterus disease have you noticed in your practice?
What disease?
Bacterus, Bechtrews.
No, I don't know what it is.
Fine. We'll move on to the next.
No, I can. What 1 minute? What did he call it?
Bechtrews.
Wait. D-U?
B-E.
D as in David?
B for baby.
Okay.
E for egg, elephant.
Mm-hmm.
C H T R E W S. Bacterus.
Oh, Bacterus disease. I've not even heard about it. I'm just looking it up.
Fine.
It's very. Oh, it's another name for ankylosing spondylitis, man.
Oh,
I just talked about ankylosing spondylitis. I have seen tons and tons of it. Yeah, I can tell you right from India. I don't know. We have been very lucky. I don't know whether they do it in Madras College now. When we went to Madras School of Physiotherapy, we had a 15-day exclusive part of internship. We had to go to rheumatology department. In those days, there used to be a rheumatology floor in Madras Medical College run by a rheumatologist. There was a 50-bedded ward for rheumatology in Madras Medical College General Hospital, and we had extensive training there. So yes, I have seen all sorts of arthritis there. We have seen acute rheumatoids, ankylosing, psoriatic arthropathies, all sorts of SLEs, systemic lupus erythematosus, all of it. Yeah. Ankylosing spondylitis, I already put it in the red flags too.
Fine, sir.
Thank you for telling me there's another name for it. I've never heard about it. Yeah.
We all should thank. Sir, how do you
learn
manage?
Every day, man.
Yeah, how do you manage patient load and your stress levels, particularly a day where you manage patients more with the flags?
Stress level? Yeah, you know what? That's something you have to work on. You have to survive. At last the survival mode kicks in. When you have bills to pay, you automatically are okay, man. You will do it. Yeah, that's a good question though, because you know what? They are right. There is a high rate of burn out if you're constantly working, you know, and we do. We used to do, see, now we have slowed down a little. We used to work almost 60 hours continuously. I have one point of time, I've done 100 visits a week. So now we are doing about 70 a week, about 70 visits a week. Yeah.
Fine, sir. Then a question in the YouTube live: why physiotherapist deals patient with physically, but not cognitively in respect of pain? How to make sense of pain to the patient, especially chronic pain?
Excellent question. Excellent question. You know what? It is that I'm talking about. We are as physical therapists. That's what, if you read at that article I put in for the OSPRO tool too, they will tell you clearly the physical therapists have not been trained. See, this started as a movement after David Butler and, you know, Mosley and all of them, you know, pain education seminars. They did a lot of work on educating. Now there is Andrew, what is his name? Andrew Lowe, however, is a South African guy. He's from in the United States. They are all doing immense amount of work on how to assess the psychological things and incorporate it as a treatment strategy. And the question is very good. We do not, like I told you, from the moment the patient enters my clinic, we are treating them in the bio-psycho-social model. I'm not looking at them as a pure disc herniation. Okay, and little example. A person will come with a pure disc herniation. Okay, they have all the signs of disc herniation. All right, but they are in so much psychological stress. Somebody told that there's a disc herniation and their leg cannot come up. Oh, they're going to end up in surgery. This will happen, that will happen. But I can show them research and proof that 80% of all disc herniations self-reabsorb in 4 to 6 months. So when the patient hears this, they say, oh my God, okay, there's only a small percentage of them. I tell them, look, if this gets any worse, and if I see progressive neurological disorder, only then you need to do something. Otherwise, you do not need to, because clearly that article that I first put on the international framework for red flags, it will clearly say that person with disc herniation does not, the probability of red flag for a person with disc herniation is really low, unless and until there is progressive neurological deficit. They even talk about whether needing MRI. The only time they need MRI is if they come in and they developed a foot drop after their back pain started. Then you can have a thing. But if they're not developing a foot drop and their pain is there, and that does not even a necessity for an MRI, there is no bowel bladder or a cauda icona signs, you don't need even that stuff. Okay?
Fine, sir. Fine.
You should get them. But that's a very good question. Why did you stop there? I'm saying don't stop with physical and cognitive. You know how much important it is. Have you ever thought that if the person has seen a doctor and the doctor has advised them to take anti-inflammatory medication and the person doesn't even understand, you know how common it is? Most people think that Brufen is pain medicine. They'll come and say, I don't want to take pain medicine. I said, you're not taking pain medicine. Who said Brufen is a pain medicine? Brufen is an anti-inflammatory. We want the inflammation decreased because the radiculopathy is a compression of your nerve root in the canal, isn't it? And it could be from swelling. And the ibuprofen or steroids they put you on initially will decrease the swelling. And it is important in your role to explain that to the patient too and see how much better your results will come up to be. Okay, I think that answers the question. Very good question. Yes, every physical therapist have to start learning the cognitive aspects of pain, especially chronic pain, because chronic pain has a higher amount of yellow flags.
Is there any other online tool to make this screening easy? I think OSPRO will do, I think.
Yeah, OSPRO is, you know what, that's very good, because I think OrthoPT, the website, or APTA's orthopedic section has an online place where you can apply this tool. But you have to have the questions with you in your hand. You can ask your patient and you can input it. So it will come out and give you the scores.
Fine. Then how can we differentiate gravity-dependent edema and DVT swelling in post-surgical patient?
Yeah, that's what I told you. See, we do not look gravity-dependent. If the person has a Wells criteria, remember I gave you the Wells criteria, and it's especially found to be pretty effective if you are in outside setting. They found that it is not as effective in the hospital setting, but outside the hospital, outside the hospital in clinical, in community setting, if your Wells criteria, you go through that Wells criteria, and if they are less than 2, DVT is unlikely. could be gravity dependent edema. But if it is greater, equal or greater than 2, immediately send out. You have no other option. You have to check out, rule out DVT with an ultrasound. And if that rules out, then you can claim it a gravity dependent edema. Okay.
Okay. And next question. The other question, Baxter's is not typical ankylosing spondylosis, sir. This presentation is different from cervical to SI joint. There is something different, is saying.
Unfortunately, I'm sorry, I don't.
Fine.
I don't
as a dry needling therapist, please give your experience on dry needling shortly.
Yeah, see, as a dry needling therapist, I am certified. I don't use it as a primary tool. A lot of people think dry needling is the end of the day. And like Vishal and others know, I tell everybody, physical therapists have to have all sorts of, like your president said and everybody said, techniques have to be learned. Okay. But technique is not the prime treatment. So how can I explain it? Okay. Think about it. If I call a plumber to come to my house, all right, I have a motor broken. So I call the plumber to come and fix my motor. And he comes only with a hammer. How confident are you that he's going to fix your motor? You want him to have all the other tools, isn't it? So like that, a physical therapist has to have a bag of tools. And one of the tools is dry needling. Okay. And is dry needling the end of the road? No research. Even recently, a study came out looking at dry needling versus other treatment in cervical spine. And they said there is no special indication to do. Why am I saying this specifically for cervical spine? Because one of the biggest complications when you do dry needling is puncturing the lung, which is closest to in the upper trapezius, you know. Why would I do that when I have great response with manual therapy treatment for other stuff? So I use it as a last resort, especially in the extremities. I have some good response with hip, deep muscles like gluteus minimus and gluteus, and also in shoulders. That's where I use, and I don't use it extensively, and I use it like sporadically when there is all other modalities are not working, because that's not my first calling and it's invasive introduction, especially places where high infections are there. I don't want to introduce it myself.
Fine.
Because the efficacy is not that high. That's what I'm trying to say.
Fine. And the last question, how do you go about with the pain education and the management of social factors for a patient with a lot of psychosocial factors? Do you tend to overload them with a lot of info or in the initial assessment itself, or you find good success with it, or you do take 2-3 sessions to ease them into the pain education and with sorting out the social factors?
Exactly. You are right. You don't want to overload them on day one. You know, I take salient features of their fear on the first aspect, and then slowly build them into the pain education as each session. You know, I'm always doing pain education in each session, and it's a wonderful question. You don't want to overload them with all the information. Sometimes it backfires by the patient thinking that you think that they don't have pain and it's all in their head. You know, so that you don't want to give them that thing. It's a wonderful question. Yes, you have to. Pain education is an ongoing process. Every session, and based on their whatever they are doing, you can use the pain education for what they are doing. And I think that's a wonderful question, and that's exactly how you should do. You should not overload on day one, and every session you should do a little bit of it. And it will be helpful if you have a tool like Yaspro, where you can find out which domain is problematic.
Thank you, sir. Now we move on to the vote of thanks. I request Dr. Sabida S, IAP Women's Cell District Coordinator, Pathanamthitta Chapter, to deliver the vote of thanks to extend our gratitude.
Hello, a warm good evening to all of you. All of you enjoyed the wonderful session. Never stop learning, because life never stops teaching. The beautiful thing about learning is that no one can take it away from you. It's already too late. It's my privilege to propose a vote of thanks and acknowledge the contribution to those who worked really hard to make the event possible. I, Sabdayes, on behalf of IAP Pathanamthitta branch of Kerala and the entire fraternity of Indian Association of Physiotherapists of Kerala chapter, extending sincere thanks to the Almighty for making today's webinar a grand success. On behalf of IAP Pathanamthitta branch, I extend a hearty vote of thanks to our branch president, who is the presiding meeting, Dr. Nishad, who is an enthusiastic and energetic person who encourages us in all and future endeavors. Thank you, sir. Next, I want to thank our chief guest, Dr. Rajivashni ma'am. She is the national treasurer of IAP. She spared her time from her busy schedule to grace this occasion. An event like this cannot happen overnight. The wheels started rolling, wheels they go. It requires planning and bird's eye for detail. We have been fortunate enough to be backed by a team of very proactive and dedicated physios of Kerala, led by Dr. Srijitnam Nambudiri, the guest of honor of this function, president of IAP Kerala chapter, who is the backbone and pillar of our he's a backbone and pillar of our national program. I extend my sincere thanks to his involvement and organizing a national webinar for the physiotherapy community. Thank you, sir. Thank you for being with us. I must mention a deep sense of appreciation to our today's resource person, Dr. Raghu Chovvath. He is a great teacher and a great scholar and great clinician. You are truly made this day enlightening for us. Your deep and intellectual way of imparting knowledge has added to this glory of this webinar. Sir, you explained red and yellow flags in various conditions and a differential diagnosis in short span of time. It's very useful to the budding physios and also the working physios in various aspects of clinical settings. We are also inspired by your great words. We have no words to offer a gratitude for you, sir. Thank you for being with us, waiting for another wonderful section. A special mention to our respected patron and Vice President of IAP Kerala chapter, Dr. Vinod Raj, for being the catalyst that stimulated us to our best. With a deep sense of appreciation, thank you, sir. I also want to extend thanks to our enthusiastic and vibrant secretaries of Kerala chapter and Pathanamthitta branch, Dr. Jim Gopalakrishnan and Dr. Vishal Johnson, for their fruitful effort for organizing this national webinar. I want to appreciate them, their effort for making this event informative for all of us. I would like to thank Dr. Vinci Daniel, Joint Coordinator of Women's Health Pathanamthitta. She is the moderator of today's program. Thank you, ma'am, for your sweet voice and carry out your work loudly. I also appreciate the IAP National Technical Team for their valuable support for this webinar. Thank you very much. I would like to thank all the executive members for their untiring effort. Last but not least, a big thank to each one of you attend this webinar with their presence who made the day memorable. Thank you. Thank you for being with us.
Thank you, everybody.
Thank you.
Thank you, one and all.
It was wonderful. Thank you, sir.
Thank you very
for
much,
the great
sir.
session, sir.
It was a great session, sir.
Thank you. I hope it helped.
Really, sir.
Sure, sir. Definitely.
It was really an eye-opening.
No. You guys already do all this. We are just creating. Everybody.
But sir, yeah.